Namaskar and good evening, everyone. We welcome you to today's webinar on updates on thalassemia on behalf of Thalassemics India and TPAG. Our focus today will be on challenges in the day-to-day management of thalassemia. I now invite Dr. V.K. Khanna, President Thalassemics India, Vice President Thalassemics India, Chairperson Department of Pediatrics, Sir Ganga Ram Hospital, New Delhi, to please come and welcome everyone. Dr. V.K. Khanna.
Thank you, Gaganji. Good afternoon, everyone. Welcome to the second seminar of the updates on thalassemia. It has been our effort to make these programs educative and simple without any technical details. And at the same time, we want to convey the latest developments in the field of thalassemia. We will start today's program with two guest lectures. We are fortunate to have experts who have played a big role in shaping the management of thalassemia and bringing it to today's form. The first lecture will be by our guest of honor, Professor B Agarwal from Bombay Hospital's Institute of Medical Sciences, Mumbai. This will be followed by a presentation by Professor John Porter from University College London Hospitals, UK. I thank our guest speakers for accepting our invitation and sparing time. After this, we'll have a panel discussion on challenges in the day-to-day management of thalassemia. Friends, with the current and optimal management of thalassemia, we expect our children to grow old, rather I would say have a near normal lifespan as well as quality. We want them to have a very good quality of life and a normal growth and development like their non-thalassemic friends. For this, we have to start this monitoring of these parameters at the appropriate time so that we take right action at the right time and give them, if they need, any medication at the right time. Many times we get patients who come very late and then they say, kuch to karo, kuch bhi ho kar lo. But that time we may not, these changes or damages, what I'm mentioning, may not be reversible also. So we have to act early for these. Then there are certain practices that many people are following just because they are continuing for years. And they are mainly related to blood transfusion, like giving pre-medication routinely before transfusion, or warming the blood before transfusion, or in some cases giving blood transfusion very slowly over hours without realizing that if we leave the blood at room temperature for a very long time, it may be harmful also. And I'm sure many more questions must be coming in your mind, your doubts. Please write them in the Q&A or chat box. And these questions will be answered by a panel of our experts who have looked after our thalassemia patients for years. And today, as I'm told, we have attendee, through the attending link, more than 450 delegates who have joined us. And I'm sure there would be many questions. Those who are not answered, we'll answer them later on, and we will send them by WhatsApp or mail, whatever is available with us. This panel discussion will be conducted by Dr. Amita Trehan. She is a senior consultant pediatric hemato-oncologist at Indraprastha Apollo Hospital, New Delhi. Now I want to make an announcement. Our next program on updates on thalassemia will be on 27th June, and that will be on privileges and benefits for thalassemia. Now I invite Dr. Lalit Mendiratta. Dr. Lalit Mendiratta is the president of IAP Delhi and is a very senior practicing pediatrician. I would request him to say a few words on the role of practicing pediatrician in the care and prevention of thalassemia. Dr. Mendiratta, please.
Thank you, Dr. Khanna, and I hope I am audible.
Yes.
Yes. Thank you, Dr. Khanna, for the kind words. And it is my privilege on the part of IAP Delhi President to be part of this unique education program on thalassemia, which is involving the esteemed faculty from overseas and our nation, and who will be guiding us as well as the patients on the day-to-day management of thalassemia. It is really a privilege IAP Delhi, who has been the part of the previous program and will continue to do so in the same manner. Now, as far as the general pediatrician concerned, I have got few things to say. That general pediatrician is in fact a bridge between a thalassemic patient and a thalassemic care center where the patient is being regularly being taken care of. We all know 10,000 children are being born everywhere. It's a huge load, and India has got the maximum number of thalassemia major chunk of the patient, major thalassemia major patients in the world. And even 4 million are the carrier. So I think the important starts of a general patient right from the beginning itself, when he diagnosed the patient in the clinic. I think major patients are predominantly being diagnosed in the outpatient department in the practicing pediatricians. It has been as early as 2 to 3 months we have diagnosed patients of major. And of course, it is our responsibility in all the patients of suspected and microcytic hyperkalemia or unexplained anemia to get an HPLC done to rule out always a thalassemia trait or major if depending on the clinical conditions. And once we diagnose that, then our immediately job begins the counseling of the patient. First of all, confirming the diagnosis and then counseling of the patient. And of course, the family, the whole family is being counseled. And of course, whole family tree is being investigated for the minor or the major trait. And then it is the job of the pediatrician to refer to the particular thalassemic center for the registration and the subsequent follow-up. So I think once we have done this job, and then our responsibility comes when the patient comes routinely for the follow-up. Then we have really the challenges. And the general pediatrician has all the challenges right from the beginning. He has to make sure the child has to grow well like other children. So our job is multifold that times. We start from the basic immunization. We all know thalassemics have prone to strep pneumonia, influenza, and other infections. So our job begins right from the immunization, which we have to make sure that all thalassemics are immunized for strep pneumonia, influenza, and meningococcal vaccine, apart from the routine vaccination. Then the routine healthcare advice on exercise, diet, and nutrition, depending on the hemodynamics, depending upon the hemoglobin of the patient, depending on the in the position of the patient is. Our job is exercise and diet, which we should routinely advise. We have the dietary counselors available in our clinics, so we can always guide them what kind of diet they require, because many of them are on iron load and have got iron load. So the specific dietary regimes are there. We can always advise them. Of course, the general health advice on exercise, which is always required depending upon the hemodynamics. Then comes the dealing with the mental health issues, because many of them challenges because they have been told that your lifespan will be this. They have heard so many things because once it's thalassemia, it will not go away. We have to make sure they have to deal normally. They have to deal how to deal with the stresses of education, anxiety, depression, and so many other associated psychosocial problems. So we have always need a counseling regarding that. If we are able to do it, help us ourselves. Otherwise, we need the help of a counselor who should always guide them on the mental health issue. I think these 4 components are very, very important. And then comes the challenges of on during follow-up when the children are, second important component is the infection which they are very, very prone to it. So our job is in any thalassemics who come to us in the outpatient department to detect infection, because this is the second most important cause of morbidity and mortality in children with thalassemics. So we all know what the various kinds of, because of the iron overload, because of anemia, because of the immunological abnormalities, they are prone to all kinds of infection, viral, bacterial, and even fungal. And nowadays, the challenges of COVID are there. So any thalassemics with a febrile illness, whether it is gastroenteritis, whether it is a pneumonia, we have to take it very precautiously, because the immunological dysfunctions are very, very common in there. And this is the very, very important, because once we detect them, even just say the example of a dengue fever in thalassemic child. So I have to be very careful in management of dengue fever, even simple malaria which they are prone to. So all the infective components which are very, very important, right from viral, bacterial infections, even typhoid fever in thalassemia, it will be a challenge for me, because I have to make sure that the response may not be that prompt. And similarly, the gastroenteritis sometimes which can mimic as appendicitis because of Yersinia and other things. And finally, that bridge, we always form a bridge between the thalassemic center and the patient, because we will be always be a guiding force. We'll be telling them, and in what condition you have to seek the advice of a thalassemic specialist, the hematologist, and what can we do best for them in the outpatient department when he needs admission. So I think we always have a challenging roles as a general pediatrician, and it will always be a good bridge, because pediatrician is a one general pediatrician who keeps on following up the thalassemic child till puberty. And of course, as the child grows older and older, puberty issues may come. So then we need the help of endocrinologist also. So at all steps, I think the pediatrician role is very, very important, and it will always be a bridge between the thalassemic care center and the patient. So the importance of, I think, general pediatrician is always there in routine day-to-day management. And today it will be another session on day-to-day management, and we all will be wizened by the inputs given by the esteemed faculty. I think this is all I have to say. Thank you.
Thank you, Dr. Mendiratta. As you rightly said, that we have to jointly look after these thalassemia patients and provide them the best possible care. Now I invite the chairperson of our coming session, Dr. Sunil Bhat, who is Director and Clinical Lead Pediatric Hemato-Oncology and Blood and Bone Marrow Transplantation, Narayana Health Network Hospitals, Bangalore. He's also Honorary Secretary of PHO chapter of IAP. Dr. Bhat, please take over and start the next session.
Good afternoon, everyone, and thank you, sir, for the nice introduction, and thank you, Thalassemia India, for giving the opportunity today and be part of this meeting today. I think this is coming, at the back of the World Thalassemia Day, which we have been celebrating in May every year, and these updates on thalassemia, which has been started with Thalassemia India and also by other patient advocacy groups, are going in a long way in spreading the information, in educating not only the physicians but also the thalassemia patients themselves as well as the caretakers. And I know that the people who have logged in today are both physicians as well as the patients and their caretakers. And I think these are of immense value. And thank you for giving this opportunity. So I will start the proceedings. I think we are short of time, and it gives me immense pleasure to introduce Dr. B Agarwal. I think he doesn't need any introduction to anyone in this country who has anything to do with hematology and thalassemia care. His contribution to hematology has been immense, and if I'm permitted to use the word, he has been the father of hematology in India. And I think he's single-handedly made hematology, I would say, so famous in India as a specialty. Decades of service to teaching and research. I think he has been involved in training hundreds of hematologists like myself, both direct and indirect, both formal and informal ways. And it would be exaggeration to state that probably he must have conducted the largest number of teaching sessions, both in person, classroom teachings, conferences, webinars, and exposed to us probably to the one of the vast gamut of international faculty who are stalwarts in the field, and we have in our homes, in our in our own towns, listened to such stalwarts, all thanks to him. The weekly sessions which is conducting through the Bombay Hematology Group at this point of time, and the last 1.5 year, as we have not been able to meet personally, I think is the most recent example. I would say that he's the teacher of the teachers. I think some of the panelists here and the faculty here who are on this platform would agree with that he has been mentoring all of us, and in my personal capacity, I'll say he has been a great mentor and teacher to me, and also continues to inspire young medical students to take up hematology in this country even today. And I'll say that 2 of my fellows at this point of time who are training with me have been inspired due to his hematology teaching in their undergraduate and postgraduate trainings. So that was about hematology and his contribution. But I think, knowing him personally, I know his discipline, dedication, sincerity is exemplary, and he's a great motivation to all of us. You write him an email at any point of the day, and I don't know whether sir sleeps or not, but even at 12 o'clock, 1 a.m. in the morning, you said write him an email, and bang on, in half an hour you get a reply back from him on whatever you have asked him to comment on. And he's been talking today on thalassemia care in India, the journey so far and steps forward. I don't think there would have been a better person than him to be talking on that, because I think his contribution to thalassemia, both in the context of direct patient care, in this clinic, advocacy, patient education is beyond expression. I don't think I can even express them in words. Every thalassemic patient and families know them in this country. I remember a prescription a few years ago I saw, which sir had written in late 1980s. And as we all know, his prescriptions go in pages and pages, with a lot of information about the particular condition, the disease, and what it mentioned. That was 1980s, late 1980s. It mentioned that with all the information which was there, it also mentioned that a bone marrow transplant is a curative option, although it's very primitive in India at this point of time, but Italy has done a good progress, and that's one of the things which you can also explore. That was 1980s, and remember, these were days where computers were not there, and it was all typed. And then in early 2000s, gene therapy got added to those prescriptions and the patient education notes. So I think I can go on and on for forever if talking about sir, but I think I would let sir to take the podium and share the thoughts about what he has for us today, how long we have come, and what he dreams and has a vision for thalassemia care in India. Thank you very much, sir, for being here today and sparing your time. Over to you, sir.
Thank you, Sunil, for your kind words. I'll just share my screen. So, optimizing management of thalassemia, the journey so far and the road ahead. Update on thalassemia. Right in the beginning, I thank Dr. Amita Mahajan and Mrs. Shobha Tuli for having me for this program. In thalassemia, we have various shades of diseases. And when you're talking about clinical management, we have probably 2 entities, the thalassemia major and thalassemia intermediate. The most important is health-related quality of life. These 2 kids don't look different from normal, though they are thalassemia major. And these 3 grown-up girls also do not look different from thalassemia major, though all of them are thalassemia major. There are various tools and methods to achieve this. Transfusions and chelation will be discussed by Dr. Porter, and I'll move beyond that. First challenge is splenectomy. Many of thalassemics have lost their spleen. And the reason for that is that the splenomegaly is causing clinical issues. The spleen becomes very large, painful, or it is eating up the blood. Clinicians ask for the spleen to be removed. This results into decrease in the transfusions, and this results into increase in hemoglobin. However, this is at particular cost. Splenectomy leads to more infection, pneumonia, meningitis, sepsis, and someone can die because he doesn't have spleen. Less often recognized, it can lead to thrombosis. Vein may get thrombosed. There can be pulmonary hypertension, can be leg ulcers, can be silent cerebral infarcts, and these are under discussed. Also, there is increased iron-related organ morbidity. So goal in 2021 is not to do splenectomy till possible. Talking about infections, all thalassemics should be vaccinated against pneumonia, against jaundice, that is hepatitis B, and in present era, if the age permits, COVID. The next challenge is the bone disease. It's very important for thalassemic to have good bones. And if that is not looked after, the bones become osteoporotic and they can fracture. This requires that bones are studied by DEXA scan after the age of 18 years, every 2 years. And to prevent bones from becoming weak, most important is regular physical exercise, good chelation, maintaining good hemoglobin, replacing calcium and vitamin D, intermittent zoledronic acid or denosumab, and managing the endocrine disorders, and no smoking. The next challenge is extramedullary hematopoiesis. And these are some images of extramedullary hematopoiesis. And the worst is when it happens in the paraspinal region because it can lead to paraparesis. Common site is dorsal spine. It can happen in 40% of thalassemia intermediate. Splenectomy is a risk factor for producing these kind of extramedullary hematopoietic foci. You don't need a biopsy to diagnose them. It's clinical plus imaging. And low dose radiotherapy, just like 100, 200 rads are enough to control them. The next challenge, which is less recognized, is the renal disease. There are various important factors: hypoxia, iron overload, and the iron chelators, especially deferricidox. And this could be glomerular or tubular damage. Some beautiful article, this one by Dr. Tahir and his group, about the mechanism of renal disease in thalassemia. The next issue which is not recognized is malignancy, and especially development of liver cancer, what is called hepatocellular carcinoma. In thalassemics, responsible factors could be iron overload and the hepatitis C and hepatitis B. Common after the age of 45, many are hepatitis C positive. Screening cannot be done with alpha fetoprotein. The most sensitive method is to do yearly sonography after the age of 40. The next challenge is thrombosis. There are various reasons why a thalassemic develops thrombosis. An important one is abnormal red cells. Splenectomy, which leads to an excess of platelet and again abnormal red cells, iron overload, and various other factors. This could lead to venous thromboembolism. This could lead to infarcts in the brain. And this could lead to pulmonary hypertension. The next challenge is the cardiac complications. The cardiac complication could be in the form of cardiomyopathy, which could be a dilated one, or restrictive cardiomyopathy related to hypoxia, anemia, and iron overload. Iron overload can produce various kinds of pictures in the T2 star, like you see over here. Less iron, too much of iron. And this could be quite discordant from what happens in the liver. As you see here, liver is okay and here liver is bad. Again, less commonly recognized as the arrhythmias. And sudden death can happen in thalassemia because of the cardiac arrhythmias, which is secondary to the iron overload. Another challenge is, of course, the endocrine organ damage, which starts very early in the life. Pituitary, pancreas, gonads all get damaged. If you look at the age structure, the growth failure starts very early. Delayed puberty, diabetes, and hypothyroidism all can occur. If you do not pay attention to this, you may remain short for the rest of your life. And timely administration of both hormones can prevent that. It's also very important that the girls and the boys develop puberty at the right time, or else it can lead to, once again, deficiencies for the rest of the life. It's important that the thalassemia major and intermediate are monitored, and this monitoring includes hemoglobin, iron, not only ferritin, but even T2 star MRI, liver status, sugar, calcium, various viruses, DEXA scan for BMD, and looking for the endocrinopathies. Treatment of thalassemia is difficult. It's lifelong, it's expensive, it's cumbersome, it's painful. It leaves behind its sequelae and morbidity. One single goal for any family with thalassemia major and many of thalassemia intermedia is to remember that their child is curable. And they should aim for that cure. If it's not possible today, then tomorrow. And this is by bone marrow transplantation. There is no child who is not a candidate for bone marrow transplantation, irrespective of whether he has a donor or not, irrespective of whether he has funds or not, irrespective of how remotely he stays in which part of the country. So bone marrow transplantation is also called stem cell transplantation. And one should start searching for the donor the moment a thalassemia major is diagnosed or some of the bad thalassemia intermedia. This could be a sibling, this could be an extended family, or this could be from an unrelated donor. If nothing, then it could be a haplotransplant, and our chairperson is a champion of haplotransplant in Bangalore. Umbilical cord transplant is another activity which has been carried out in this country and the rest of the world. However, it is becoming obsolete. What does the future lies in? So this is the ABCD of future. The A is for the gene therapy and hemoglobin F induction. B is JAK2 inhibitors. C is many hepcidins. And D is reducing the production of alpha chain. Today, we'll not discuss C and D. We'll spend some time on A and B. So treatment strategies discussed so far have various limitations. And therefore, there are research to improve the ineffective erythropoiesis, and there is research to improve the iron dysregulation. One of the important drugs is hydroxyurea, and unfortunately, this has not been properly studied in clinical trials at all. Another one is thalidomide, and once again, it is extremely poorly studied. Both these drugs have their toxicity that hence have to be used very carefully with a lot of restrictions in the hand of specialists. The one which has been very well studied in controlled trial is luspatercept. And this is very effective in increasing the hemoglobin and in dropping the transfusion requirement. It also helps in healing of the ulcers. Sooner or later, the cost of this drug should come down, and then it should be useful to the third world as well. It's available by this name, Revlimid, in this pack, and there is a patient assistance program available in whichever countries it is officially marketed. As far as the JAK inhibitors are concerned, the drug is ruxolitinib or Jakavi. This can lead to medical splenectomy. It can reduce the size of the spleen without doing surgery. However, unlike what was expected, it did not decrease the transfusion requirement, and Novartis is no more carrying out this research. So that's a dead end to the ruxolitinib in thalassemia. The next challenge is gene therapy and especially gene editing. This is a very exciting tool. This is probably, if not a total replacement for bone marrow transplantation, is going to be a good addition and almost cure for many thalassemics. But this is far away for all of us, maybe at least 5 to 10 years away. The cost of the therapy is going to be exorbitant for almost next 1 decade or more, and there could be unknown adverse effects in the long term. Today, all of us have patients who have survived beyond 50 years. This is a couple of which I'm proud of. Boys from Mumbai, the girl is from Delhi. Now they are married to each other. The life is wonderful for them. Pregnancy is no more a distant goal for a thalassemia major. And this is our thalassemia major who is now a mom. She's from Ahmedabad. She's Thal major, and that's her baby. I think slowly and steadily we are ticking all the boxes in the care of thalassemia and its cure. Still, treatment of thalassemia or cure of thalassemia is not within resources of most of the patients, and 90% of the thalassemics live in the third world. Prevention is the key, and prevention of thalassemia is possible. There are 4 pillars: awareness, and I think everything that you do in thalassemia leads to more awareness. Carrier detection, which is accurately possible all across the country. counseling, and that is a very important part of prevention, and then prenatal diagnosis, and even pre-implantation genetic diagnosis. We still have a long way to go. World Thalassemic Day gives an opportunity for us to meet every year. In our own way, we do these small thalassemia meetings in Mumbai. And this was one meeting, which was the last one because of the COVID, held in April 2019. And there have been speakers from all around the world who come physically to devote their time to educate us. Abraham Lincoln had said, "I walk slowly, but I never walk backwards." So there is never to be any pessimism. Be optimistic and carry on with whatever the best possibilities are there in front of you. Always remember, the goal should be, how can I help you? Well, thank you so much, and I'll stop.
Thank you very much, sir, for that lucid, to the point presentation. I think you have covered most of it. You have covered what we have achieved so far, and I think what's in the pipeline. And I think more importantly, the representation through patients. The long way we have come. So thank you very much for that, sir. So we'll go on to the next session, which is going to be on, next talk is going to be on the blood transfusion, chelation management challenges, as well as what is the COVID experience been in UK in thalassemic patients. And we have got none other than Professor John Potter, who is going to be talking to us on this today. Again, Professor Potter doesn't need any introduction to us. We have been listening and reading to Professor Potter for many, many years now. He is a professor of hematology at the prestigious University College London Hospital in UK. He's also the head of the Joint Red Cell Unit at the UCLH and the Whitington Hospitals. His association, to thalassemic care in India is long, and he has contributed immensely to the thalassemic care in India. He has been a scientific advisor to Thalassemic India, I think, for more than 10 years now, and has really shaped the advocacy and the contribution in thalassemic care in India. He's also been associated with the Thalassemia International Federation for many, many years, and also driven the policies around thalassemia all across the globe. So thank you very much, Professor Potter, again, for being here today and sharing your experiences with us. So what to you, sir?
Thank you for your kind introduction. Can you hear me?
Yes, we can. Yes, we can.
Okay, good. So I've been asked to talk about blood transfusion, chelation, and then give a little flavor of the experience we've had in the UK with COVID-19. I know this is something which is very pressing in India at the moment. So it's a wide range of subjects. So I'll get started. So I'm going to talk about the goals of transfusion in thalassemia. What are we trying to achieve?
Professor Potter, can you please share your slides?
I thought I'd done that. Let me try again. Okay, share screen. And go. How is that?
Yeah, it's fine now. Thank you.
Thank you. So I'm going to talk about the goals of transfusion. And I'm going to ask the big questions, not the minutiae, which we can maybe cover in the discussion. I'm going to talk about theoretical aspects of transfusion targets, because there may be some justification in thinking about what our targets are and why we use them. I'm going to talk about the evolution of chelation therapy, how we've got to where we are and what the options are now, but that's going to be fairly top line. And I'm going to look at the impact of these transfusion and chelation policies when combined together on survival. And then I'm going to switch completely and talk about a little bit of experience of COVID in the UK. We've had a pretty terrible time, but I know you're having a much worse time now. So for a long time, we had the highest number of deaths per capita in the world. But with the introduction of the vaccine, that has changed radically. So the next slide talks about the relationship between the needs for transfusion and the severity of disease. And as you mostly appreciate, thalassemias aren't single entities of non-transfusion or transfusion dependent. It's a spectrum. And the amount of blood that is optimal for a patient needs to be gauged at any moment in time and may change throughout the life. The non-transfusion dependent patients tend to be transfused sporadically. The amount of blood that is given is key to what happens in terms of ineffective erythropoiesis and peripheral hemolysis. But as a general point, anemia can be progressive with time. So some patients who start not requiring transfusion may require transfusion later in life to maintain quality of life. And there's this overlap of number of issues going on in non-transfusion dependent patients, which include the anemia itself, the thrombotic complications of the abnormal red cells, the other complications of hemolysis, such as gallstones, leg ulcers, and the effects of iron overload, liver disease, although iron overload tends to be less of an issue in the non-transfusion dependent patients. In transfusion-dependent thalassemia, these patients tend to start transfusion early in life, in the first 2 or 3 years. And the main driver of morbidity is secondary iron overload, or was until we managed to do better with chelation management. And the onsets of complications can start early or not present until later in life, depending on the quality of transfusion and chelation. So what we're trying to do is we're trying to correct the anemia, which is self-evident, but we're going to try to optimize growth. And it's been shown that the current transfusion regimes in transfusion-dependent patients improve growth and improve well-being. And I'll show a slide of what the current recommendations are. Suppression of ineffective erythropoiesis is also very important. When we investigate patients for other reasons or we do MRIs, we find a lot of patients have both intramedullary and extramedullary expansion, even though they're ostensibly thalassemia major. So it's much more common than people realize. And also, an objective of an intensive transfusion regime is to improve well-being and to improve the production of abnormal red cells, which in themselves are prothrombotic. Now, what is the optimal hemoglobin to transfuse? And that, to some extent, depends on local circumstances. Most of the evidence that we use in the thalassemia guidelines comes from Italy. There are advantages of higher pre-transfusion hemoglobins because we suppress the bone marrow more and we stop this extramedullary hematopoiesis. Patients have better energy and quality of life. The disadvantage of a higher hemoglobin, however, is that there is a greater use of blood on average. There's a higher iron loading rate and there's less clearance of non-transferrin bound iron. And I'll come back to that. So in studies that were previously done, we know pretty well what the transfusion requirement, the iron accumulation rate is based on the number of units of blood given and the hematocrit. I'm not going to go into great detail on that just now. So the mean target average hemoglobin, according to TIF guidelines, is 12 grams per deciliter. And that means that after transfusion, we want a hemoglobin of between 14 and 15, and pre-transfusion, a hemoglobin between 9.5 and 10.5. And that's shown here. And the interval between transfusions is typically between 2 and 5 weeks. I know in many parts of India, transfusion is given every week for organizational reasons, and there's no problem with that. This regime, as I say, promotes normal growth, suppresses ineffective erythropoiesis. Now, this slide I wanted to show you because it shows the effect of the pre-transfusion hemoglobin on suppression of the bone marrow. And the suppression of the bone marrow is measured by something called soluble transferrin receptors, which are shed by the developing cells in the bone marrow. And you can see that to get the levels of these soluble transferrin receptors down to normal, you need to get a pre-transfusion hemoglobin between 10 and 11, which is not actually what we do. What we do is we do between 9 and 10, when the expansion of the bone marrow is between 1 and 4 times normal. I'll come back to why I think that's important. And this was the pivotal study that we've used for many years in the guidelines from Italy, where they took the same patients on a low transfusion regime and a high transfusion regime, the low being not particularly low, an average hemoglobin of 9.5 pre-transfusion, and a high one with an average pre-transfusion hemoglobin of 11.3. And they showed that they could control ferritin better on the low transfusion regime, and the number of units of blood, the amount of blood given, was less. This is some work that my research fellow, Dr. Garbowski, did, and he was looking at risk factors for myocardial siderosis. And what he found was that the biggest risk factor was the amount of blood that was given relative to the hoovering up of iron from transferrin and of non-transferrin bound iron in the bone marrow. It was the highest risk factor. And you can see that here. So you can see on the horizontal axis, soluble transferrin receptors and cardiac iron. And in the patients who had the highest production in the bone marrow, or highest activity in the bone marrow, had the most normal cardiac iron. So that makes us think that we may need to revisit what the optimal recommendations are. I'm not saying we should change them at the moment, but I think we do need a study to optimize the amount of transfusion we give in each local setting. There are other risk factors from blood transfusion, infections, alloimmunization, iron overload I've already covered. And less commonly, we can get febrile non-hemolytic reactions, allergic reactions, acute lung injury, so-called TRALI, acute intravascular hemolysis. And you can get delayed alloantibody formation with hemolysis. These are well known, but they do occur even today. I would make the general point that if you start transfusion early in life, you're less likely to run into problems with some of these hemolytic reactions than if you start late. Now, this is a timeline of the evolution of chelation and monitoring in thalassemias. And of course, in order to target your treatment, you need to understand what you're treating. And I won't go into the discovery of the different structural aspects of thalassemia, but you can see that began in the 1920s. Key advance was Weatherall and Clegg's description of the globin chain imbalance, and the genetic diagnosis, prenatal diagnosis, was absolutely key to antenatal diagnosis and monitoring in the 1980s to 2000s. And this is how the evolution of treatment fits into that. So Desferal actually first became available in the 60s, but wasn't really used effectively until the late 70s, when subcutaneous desferrioxamine was given. And we've heard about bone marrow transplantation. That came in from Lucarelli's group in the 1980s. Geferiprone started to be used in clinical trials in London in 1987. CMR, MRI estimation of heart and liver iron came in 1999, it started, and deferosarox was finally licensed in 2005. So we now have 3 chelator regimes available. During that time, the mortality in thalassemia in the UK, in our centre, has fallen from 12.7 deaths per 1,000 patient years down to 1.5 per 1,000 patient years. So this treatment works. What we're constantly having to do, however, is to balance the effects of too much chelator against the effects of too much iron. And this is a balance, because many of the effects of chelator, the unwanted effects, relate to overchelation, either of iron or of other trace metals. And we know, for example, we can get neurotoxicity, we can get growth failure, we can get bone marrow toxicity with some of the chelators used. And this is a slide showing the characteristics of the 3 licensed chelators worldwide: desferrioxamine, deferriprone, and deferrisarox. Most of you know these. I'm not going to go in great detail about that now, but an important point is, certainly with desferral and deferrisarox, we need to adjust the dose, both for the degree of iron overload that it already exists, but also the rate of iron loading. That's really key to getting the maximum efficacy to toxicity. And these are well-known slides to many of you, showing survival in thalassemia major has significantly improved since the introduction of chelation therapy. It's an effective regime, but it's not perfect. Here you can see in the 1950s, people were dying mainly of anemia, as shown in pink, but that ceased to be a problem in many, certainly in the UK, by the 1970s. We started to get more and more people dying of cardiomyopathy with heart failure. But with the introduction of chelation, you can see on the right panel here, that has fallen away very substantially. And we're getting more problems from liver iron, either malignancy or infection with hepatitis as a problem. So we're tending to see more liver problems, more malignancy as causes of death, and less cardiomyopathy than we did, say, 10 years ago. The age distribution, this is our clinics in London. It's a strange distribution because it shows that the average age in this clinic is about 35. And you can see there aren't many patients of age 65 around, but there also aren't many patients less than 10 years. So we've got an effective prevention program, and we've got an effective treatment program. And you can see the average age of the patients is going up with time. But there are remaining issues with transfusion chelation. It's been estimated by Medell that only 12% of children globally receive adequate chelation and transfusion therapy. Less than 40% of those transfused receive adequate chelation, so only 12% of patients get adequate transfusion according to Medell's estimates, and only about half of these who get good transfusion also get good chelation. The other problem is cost. You heard from the last speaker how expensive gene therapy is, which it is, of course, but we have to remember that providing good monitoring and treatment over a lifetime, say to 50 years of age, in the UK, it's in the region of £500,000 by the time the patient reaches 50 years of age. It'd be less in India, I appreciate, but it's still a lot of money. And the costs have also increased as the treatment has improved. So the cost, for example, of doing monitoring of cardiac MRI and liver MRI adds to the cost, quite apart from those costs of chelation. So that's where we've got to with transfusion chelation. I'm sure we can discuss more in the discussion panel. I was asked just to say what we have been experiencing with COVID-19 in the UK, and this is from work that's put together by Ralph Brown, Speta Sohal, José de la Puente, and Mark Layton, who kindly allowed me to show these slides. There's a national panel which I sit on when we go through the data. Now, this is the UK experience with COVID. You can see in the top panel new cases, and in the bottom panel deaths. And you can see that we've had 2, possibly 3 waves, depending on how you want to define it. The last wave was particularly bad, that started after Christmas, and it has fallen away very dramatically, both with lockdown and the institution of vaccination. And here we can see vaccination with time in the UK as a whole, and you can see that about 30 million patients have had at least one vaccine so far, and the daily rate is about 400,000 vaccines a day in the UK at the moment. And this is, I'm slightly, I'm flying without without an altimeter at the moment, because I can't see all my screen, so I'm trying to remember what it said. But I think this shows the share of people who've received at least one dose of COVID vaccine by country. And you can see that in the UK now, we're fairly high up. About 50% of adults now have received at least one dose. And you can see how that compares with India, where it's obviously less. It's more like around 10 or 12%. But I did want to make the point that, and I can see the problem. If you take total vaccinations, India is the second highest country in the world. So if you take the proportion of people in the country, it's low, but total number of vaccinations given, it's very high. And it's an enormous issue logistically, and maybe we can talk about that. But I'd also make the point that when the pandemic started, we got off to a very slow start in terms of contact tracing, in terms of PPE for patients, doctors, and so on. We were on a very steep learning curve. And I think it's with the introduction of the vaccination, we've managed to catch up and get things under control. And I heard this morning, interestingly, that the Pfizer vaccine is effective after 2 doses against the Indian variant, that they've got the latest data. So that's very exciting. Last couple of slides. This is data of hemoglobinopathy patients in the UK. So we collect data on all hemoglobinopathy patients. As you probably know, most of the patients with hemoglobinopathy in the UK have sickle cell disease. That's around 15,000 patients. And these are patients who've had COVID. So you can see that the mortality amongst sickle patients in the UK who get COVID is in the region of about 4%. So it's not horribly worse than in the general population. And you can see that mortality relates to age. So that if you're, for example, 20 and you get COVID, you've only got, say, a 2% mortality, whereas if you're 50, it's around 17%. So a lot of that relates to age, as it does in the general population. And here's thalassemia. We've only got 1,000 thalassemia patients in the UK anyway. So the number that we know about who've had COVID is 72, so quite a small number. And we've had 5 deaths, unfortunately, in that, which gives a mortality rate of about 7%. So it is an issue in thalassemia, and we obviously need to take special precautions to get thalassemia patients vaccinated early. How has COVID impacted on the overall care of our patients? We've had to move outpatients to virtual clinics, and this is likely to lead to long-term changes in practice. We've found that virtual clinics have their merits. There's definite problems in not seeing patients, and we've got to get the balance right, and that balance may change from time to time. But a lot of the work's been done by virtual clinics. And we've started to do video clinics now, so that will help as well. Routine monitoring has been severely interrupted. MRI, echo, pulmonary function. Those tests were put on hold during the worst time of the pandemic. Pediatric inpatient service had to move. Community home visits had to stop or be curtailed. Face-to-face psychology sessions were stopped, but actually it worked reasonably well by video link. Non-urgent surgery stopped. The thing that really has been most badly impacted from my personal perspective is research. Research trials were put completely on hold. No new trials unless it involved COVID trials, and that really has held things up. How have we adapted? We've started phone clinics. We've done virtual psychology clinics. There are blood and observation satellite clinics. Some medicines are posted, less frequent monitoring. And we've worked around how we manage transfusion, both with swabbing and allowing access in a more flexible way. That's involved a lot of changes. So that's just a brief overview of how COVID has in fact impacted it in the UK. It's been a difficult time, as I'm sure it is being with yourselves now, and maybe we can talk about that more in the discussion. Thank you very much.
Thank you very much, Professor Potter. I think that was a really nice summary of the development both in transfusion as well as in the chelation of the last few decades. I think you tried to make the point and convinced all of us, and also to the delegates who joined in, that how important it is to maintain the pre-transfusion hemoglobins of 9.5, 10.5, and what's the what's the rationale behind that. I think that's probably one of the important messages I think we will take from here. So thank you for your time again, and we will be using your expertise again in the question, answer, and discussion session. And I'm sure there'll be many more questions on COVID, especially at this point of time. So thank you for the opportunity, and I'll hand over to Dr. Amita Mahajan for taking the question, answer, and the discussion session forward. Thank you very much.
Thank you, Professor Porter and Sunil. Thank you for conducting the session so well so far. So I'm going to take on the next part of the session, which is the panel discussion. And I'd like to say at the outset that most of the questions have come from the parents and the patients. And it was really heartening to see the context and the tenor of the questions, because you know that patients are doing well when they start asking you more complicated questions and questions that challenge our own expertise. So you know that maybe transfusion, chelation are not just the burning issues anymore. We're probably doing a better job of that there is focus now on more complex issues with, involving all other organs. There is a challenge with the language, because for these webinars, we have a very large audience from across the country. पूरे देश से लोग पूरे अलग प्रदेशों से हमारे साथ जुड़ते हैं, तो हमें कई बार ये समझ नहीं आता कि हिंदी में करें, इंग्लिश में करें या कैसे करें। तो हमने सब तरीके से कोशिश की है। पिछला वेबिनार पूरे तरीके से हिंदी में था, तो बहुत फीडबैक आया साउथ इंडियन पेशेंट से कि आप हमें तो भूल ही जाते हैं, हर बार आप हिंदी में ही बातें करते रहते हैं। आज हमने कोशिश की कि कुछ हिस्सा इंग्लिश में रहे और बाकी जो है वो कंबाइन करके हम करेंगे। एंड आई थिंक चाहे हमारी मातृभाषा हिंदी हो, मुझे हमेशा से लगता है कि इंडिया के ज्यादातर लोगों को थोड़ी बहुत इंग्लिश जरूर आती है। Probably we are the most English literate in the world, because most people can speak little bit of English. So I'll try and we combine, and maybe we will do justice to all our queries that we have received. I'd also like to share that we received a lot of questions on gene therapy, transplant, Reblozyl, and thalidomide. So the last webinar that we did was exclusively to cover these three areas: BMT, gene therapy, and newer medication. That webinar was mostly in Hindi. It is uploaded on the Thalassemics India website and on YouTube. And the end of today's session, we will be sharing that link to each and every delegate. And please disseminate it as widely as possible, because I think it was a very informative webinar. उस वेबिनार में आपके बहुत सारे क्वेश्चंस जीन थेरेपी, ट्रांसप्लांट और जो नई दवाइयां आई हैं या आने वाले समय में आने वाली हैं रेब्लोसिल को लेके, बहुत बखूबी हमारे जो एक्सपर्ट स्पीकर्स थे और बहुत क्वेश्चन आंसर में बहुत क्वेश्चंस उन्होंने हमारे आंसर किए, वो आपको लिंक में शेयर करूंगी। अगर आज का पैनल का फोकस इज ऑन चैलेंजेस इन डे टू डे मैनेजमेंट ऑफ थैलेसीमिया, तो हम चाहेंगे कि इस पैनल में हम उन प्रश्नों को लें, एंड if we have time we can take some questions, or whatever questions we are not able to answer, like the last time, I will personally be mailing the response to you, either from one of the panelists or myself, so that you are satisfied that your question should have been answered after attending this 2-hour long webinar. So joining me today for this webinar, Professor Porter and Dr. Khanna will continue to be part of our panel. We have Professor Deepak Bansal. He is Professor of Pediatrics from PGI Chandigarh. प्रोफेसर दीपक थैलेसीमिक्स के साथ कई वर्षों से जुड़े हुए हैं और हम हमेशा अपने पैनल डिस्कशन में चाहते हैं कि वो आए, क्योंकि वो बिल्कुल सीधा सपाट सरल आंसर हमको देते हैं कि किसी को भी एक्सक्यूज नहीं है कि कहें कि मुझे समझ नहीं आया. सो ही the award for giving the most straightforward answers every time gone to Professor Deepak Bansal. So he's a very valued, member of our panel discussion today. The next panelist we have Professor Anju Seth. Many of you are adult thalassemics now. आपको बहुत सारे सवाल हैं हार्मोनल डिस्टर्बेंसेस को लेके, बहुत सारे हम डॉक्टर्स के भी सवाल हैं. And to be honest, more and more we are realizing that an endocrinologist is perhaps one of the most useful partner for us in giving optimal care to thalassemics. So I thank Professor Anju, who's going to join us today. Again, she has always been there for the thalassemics, always been there for our queries, and again gives us very pragmatic responses to some complex questions that we put to her. Finally, we have today Dr. Shruti Kakkar. You all, she also needs no introduction. Dr. Kakkar has taken the mantle from Dr. Praveen Sopti to continue to deliver wonderful care to thalassemics in Ludhiana and neighboring cities. And she joins us today again to answer your questions. So I think if that's for the introduction, let's move on to the panel discussion. So I'll just share my screen. Yeah. So the first section of this panel discussion is focused on COVID-19 because that has been the overwhelming, concern for most of our patients and families. Dr. Porter ने कुछ काफी इसके बारे में हमें बताया, but कुछ specific questions वैक्सीन को लेके और इस infection को लेके मैं अगले कुछ मिनटों में cover करना चाहूँगी. Professor Porter, you did give us a good overview of how thalassemics behave with, and the data from UK seems to suggest that they may have had a more severe course. But is there data from TIFF or any other organizations that gives us a broader overview of how thalassemics have done during this COVID, specifically in terms of response to infection?
So, couple of comments. So first, when we first started to see COVID in the UK, my impression, and in fact the data that was coming through, was that thalassemia was not particularly affected, and we were getting quite a low mortality. But actually more recently we've started to see, and it's caught up, and as you saw, 7% mortality, mainly in the older patients. But still, I don't think we can say that they're protected in any way, and there probably is a slightly increased risk. The guidelines were that people who are splenectomized should self-isolate, and that was quite difficult for some people, but I think it was a reasonable thing to do. And as we know, in thalassemia major particularly, overwhelming sepsis can be a real problem, particularly with organisms such as Klebsiella. So I think you have to be very careful to avoid sepsis and take extra care about that. The key thing, of course, is getting vaccination early and getting both doses of the vaccination. And when I mentioned Pfizer, I should have also mentioned AstraZeneca. So the data with those is that it's very effective in the population in general. In our vaccinated patients, we haven't had problems with COVID. It seems the vaccination seems to be very effective. I have spoken to people in other countries, particularly in Italy, and they are of the view that thalassemia doesn't seem to be an extra risk factor. So in other words, they find that the mortality and morbidity is really sort of age appropriate. So if you're a 50-year-old man and you get COVID with or without thalassemia, it's a relatively high risk compared with the 20-year-old. Our data, I mean, the numbers are small, It only takes one person to make it look worse or better.
The average age of thalassemics in your country is also, from the data that you've shown, is quite high. That is
yes, exactly. We've got quite a few in their 50s and even some in their 60s. So that's going to skew it. Yeah.
What about patients who have undergone splenectomy? Is there any evidence that they have had a worse or more stormy course?
Not really in the UK. We've only, as you saw, we only had five deaths, mainly because we've got small numbers of patients. So the statistics on that aren't really strong. But the general point is take precautions and be particularly vigilant. One of the problems we had with the lockdown is that everybody, irrespective of diagnosis, was encouraged to phone a helpline, and you got a sort of computer says no response, and you do really need to tailor your response intelligently and in knowledge of the disease process. And obviously, if you've had a splenectomy, that needs to be taken into account and appropriately.
Thank you. Professor Deepak, Dr. Porter has shared his overview from the experience in the UK. I know in India, we don't have a formal registry to my knowledge as such, but what has been your experience? Thalassemics in India, उनका कैसे रहा है? जैसे हम लोग आपस में अक्सर इसके बारे में डिस्कस करते हैं, तो ताकि हमारे पेशेंट समझ सकें कि क्या वो एवरेज पेशेंट से ज़्यादा रिस्क पे हैं या उतने ही एहतियात लें जैसे उनके भाई बहन या बाकी फैमिली मेंबर्स के लिए रिस्क है.
So thank you Dr. Meeta Majan. So overall मैं बोलूँगा कि हमारे पास कोई बहुत strong डेटा नहीं है, बट जो इम्प्रेशन आता है वो यही आता है कि जैसे और लोगों को कोविड की प्रॉब्लम्स हो रही है वैसे ही थैलेसीमिक्स को. ऐसे अपरेंटली लगता तो नहीं है कि बहुत ज्यादा रिस्क है, बट एब्सोल्युटली कहना मुश्किल है. तो सबसे इंपॉर्टेंट चीज है कि जल्दी से जल्दी जो भी 18 साल से बड़े थैलेसीमिक्स हैं बस वैक्सीन लगवा लें. कोई ज्यादा सवाल ना पूछें, कुछ ज्यादा सोचें नहीं, जल्दी से जल्दी वैक्सीन लगा लें, जो मिलती है वो लगा लें. कॉम्प्लिकेशंस के बारे में, साइड इफेक्ट्स के बारे में ना सोचें. तो सबसे इंपॉर्टेंट चीज है वैक्सीन लगाएं, जल्दी से जल्दी लगाएं. थैंक यू.
थैंक यू डॉक्टर दीपक. और मैं यही शेयर करना चाहूंगी सब मेंबर्स के साथ कि जितना हम लोगों का अभी तक का एक्सपीरियंस रहा है, शायद हमारे ज्यादातर थैलेसीमिक पेशेंट्स यंग भी हैं, तो हम लोगों को यही ऑब्जर्वेशन में आया है कि कोई एक्सेस रिस्क नहीं है, लेकिन वैक्सीन को लेके ये लोग बहुत थोड़ा सा असमंजस में है. तो मैं अगले कुछ सवालों में उनको क्लैरिफाई करना चाहूंगी. तो डॉक्टर बंसल, आपने बहुत क्रिस्पली और क्लियरली कह दिया, तो आप एक बार उसको फिर से रीइटरेट कर दें. जितना आपने बोला है कि ज्यादा सोचना नहीं है, बस वैक्सीन की लाइन में लग जाना है.
जो पहला क्वेश्चन है कि वैक्सीन लगानी चाहिए थैलेसीमिक्स को, हाँ या ना, तो उसका आंसर है एब्सोल्युटली हाँ. स्प्लीन निकली हुई है, नहीं निकली हुई, सोचने की जरूरत नहीं. ब्लड चढ़ता है, कम चढ़ता है, ज्यादा चढ़ता है, कोई प्रॉब्लम है, कोई दवाई चल रही है, कुछ भी है, कोई कॉन्ट्राइंडिकेशन नहीं है, जल्दी से जल्दी वैक्सीन लगवाइए. जो कोविन ऐप है उस पर लगे रहिए, जैसे टाइम मिलता है, जब डेट मिलती है, जिसे कहते हैं फास्टर फिंगर फर्स्ट, कि ये मत बोलिए कि हमारे लिए स्पेशल फैसिलिटी नहीं दी गई वैक्सीन लगाने की. जैसे जो कोविन ऐप है उस पर बस घंटे घंटे पे ट्राई करते रहिए, जैसी टाइम मिलता है, जैसी स्लॉट मिलता है उस पर क्लिक करके अपना टाइम लीजिए. और नेक्स्ट क्वेश्चन है कि ब्लड और वैक्सीन के बीच में कितना डिफरेंस होना चाहिए. तो ऐसा कुछ भी नहीं है. ब्लड चढ़ने का इस वाली वैक्सीन से कोई लेना देना नहीं है. वो ये सवाल इसलिए आता है क्योंकि कई वैक्सीन लाइव होती हैं और ब्लड में एंटीबॉडीज होती हैं, तो वो वैक्सीन की एफिकेसी को थोड़ा कम कर सकती हैं. पर कोविड वैक्सीन का ऐसे सोचने की कोई जरूरत नहीं है. ब्लड चढ़ाने का दवाइयों से, वैक्सीन से कोई लेना देना नहीं. थैंक यू.
So thank you. Every single patient must register for the vaccine, take the vaccine as soon as available. And it really, what date is available is perfectly fine. Dr. Shruti, can you take us through कि अगर patient को COVID infection हो चुका है, क्या उन्हें फिर भी vaccine लेने की जरूरत है? If they've had an infection, should they still take the vaccine? And उसका infection के बाद कितने समय के बाद ये vaccine लेना चाहिए?
सो आप सबने शायद न्यूज़ में सुना होगा कि सो एंड सो पर्सन को या डॉक्टर को पिछले साल कोविड हुआ था, इस बार दोबारा हो गया, राइट? सो ये हो सकता है कि अगर आपको एक बार कोविड हुआ है, यू कैन हैव अनदर एपिसोड ऑफ कोविड इन्फेक्शन। तो कोविड के बाद, कोविड होने के बावजूद भी जैसे आप रिकवर करते हैं, आपको वैक्सीन लेना ज़रूरी है। अगर आप गवर्नमेंट ऑफ इंडिया के गाइडलाइंस देखेंगे, यू हैव टू वेट फॉर 3 months, यानी कि एक बार आपको कोविड हुआ है, उससे 3 महीने के बाद आप वैक्सीन ले सकते हैं, बिकॉज 3 महीने के बाद आप फिर से रिस्क पे हैं, राइट? सो वैक्सीन जरूर लीजिए और सारे प्रिकॉशंस जो कहते हैं हम, सैनिटाइजेशन, मास्क और सोशल डिस्टेंसिंग, प्लीज उसको फॉलो करिए।
थैंक यू। डॉक्टर खन्ना, हमारे पास अब 2 वैक्सीन ऑलरेडी हैं। कभी कोई रिपोर्ट बोलती है ये ज्यादा बेहतर है, दूसरी रिपोर्ट बोलती है दिस इज बेटर देन द अदर वन। Then if somebody says कि Russian vaccine is coming, that will be the best. Pfizer will come eventually. I can afford it. So should I wait? तो अभी आपकी हमारे पेशेंट्स को क्या गाइडलाइन है कि कौन सा वैक्सीन लें या किसी अच्छे वाले वैक्सीन की इंतजार करें?
जैसा कि अभी पहले बताया जा चुका है, कई बार बता दिया हमने, इस टाइम जो मेन फोकस जो है हमारा वो है गेट द वैक्सीन। बस एक ही पॉइंट दिमाग में रखिए, वैक्सीन करा लीजिए। जो मिलता है, जब मिलता है, जहां मिलता है वहां से करा लीजिए। जितने भी वैक्सीन हैं हमारे पास, 2 अपने वैक्सीन, कोविशील्ड और कोवैक्सीन, और तीसरा स्पुतनिक का भी जो आया, उसके तो अभी थोड़ी सी डोजेज आई हैं, 2 लाख डोजेज आई हैं। अभी तो वो अगस्त में बनना शुरू होगा। बट एनीवे, दे आर ऑल वेरी सेफ, दे आर ऑल वेरी इफेक्टिव। कोई कंपैरिजन करने की जरूरत नहीं है कि जी वो वाला वैक्सीन आएगा तो लगवाएंगे, तब तक ये ना कोविड हो ही जाए और कोई प्रॉब्लम हो जाए बीच में। बेस्ट है बस अभी आप वैक्सीन लगवाइए, जो मिलता है वो लगवा लीजिए, कुछ और सोचने की जरूरत नहीं है।
Thank you, Dr. Khanna. Professor Porter, this question has come up from patients with NTDT, that they have a prothrombotic kind of, predisposition. Should they take any precautions? Because there have been some reports, a small risk of thrombosis post-vaccination. So do they need to take, or post-splenectomized, do they need to take any extra care? Or even for other thalassemic patients, are any precautions necessary around the time of vaccination?
That's a very good question. So in general, there shouldn't be a risk and people should go ahead and get vaccinated. And I didn't hear the translation of the other answers, but I got the feeling that what you were saying was that the thing is to get vaccinated, not worry too much about which agent it is. And I agree with that completely. I've seen too many people saying, oh, well, I wanted to wait for this one, and then I did, and they haven't been vaccinated at all, and that's terrible. So the extra risk, there's undoubtedly a risk of thrombosis in NTDT, and that comes, of course, from the abnormal red cells, which are prothrombotic. The evidence that the kind of thrombosis you see post the AstraZeneca vaccine, because it's the AstraZeneca vaccine which has been the problematic one, is a problem in NTDT. I don't think the data's there, at least I haven't seen it. So if the alternative is not getting vaccinated at all, then I think the extra risk of thrombosis is very small. The data shows in general it's about 1 in 100,000. So I personally, if I was in that situation, would advise the patient to be vaccinated. If you're in the luxurious situation of genuinely having the choice of the AstraZeneca or one of the other ones, which hasn't been shown to have a thrombosis, then I would choose the non-AstraZeneca one. But the important thing is not to miss out on vaccination because of that concern.
So I hope it's clear to everyone कि वैक्सीन लगना जरूरी है. कोई भी ऐसा रिस्क नहीं है जिसकी वजह से हम सोचें कि वैक्सीन नहीं लगाना है. जो वैक्सीन हमें आज की डेट में अवेलेबल है, हम लोग सब कंप्लेन कर रहे हैं कि कितना अभी तक अखबार में हम रोज पढ़ते हैं, अरे फिर बंद हो गया कुछ दिन के लिए. But like Dr. Porter said, you have to understand that India has vaccinated the second largest number of people anywhere in the world. With all our limitations of resources and other challenges. So we are getting there. I think we just have to forget any reservations about the vaccines and just, जैसे डॉक्टर दीपक बंसल ने कहा कि दिन का 1 घंटा तो कम से कम कोविन ऐप पे लगना ही चाहिए so that you get a slot for the vaccination. Dr. Khanna, many patients have asked that, we are just so bogged down with, COVID and other things कि अब जो हमारी routine monitoring है उसका हम लोग को लगता है इतना important नहीं है. तो हम उस सबको अभी के लिए छोड़ दें या what should we do? Is that important? Please.
I think, Dr. Amita, that we should not neglect or ignore our thalassemia even during COVID time, because these children are anyway going to hospital for blood transfusion. Whenever they go to hospital for blood transfusion, they can get their, especially those monitoring for chelators, वो करा सकते हैं, अपने monitoring के test करा सकते हैं. उसके अलावा जो भी उनके अगर एनुअल मॉनिटरिंग के भी जो सैंपल्स देने हैं वो उसी दिन वहां पे दे दें. हाँ, जब बात आती है कि जब बहुत सारे केसेस हैं, एक वेव जैसे कि लास्ट मंथ हमने देखी दिल्ली में भी और भी अभी कई जगह चल रही है, ऐसी सिचुएशन में अगर उनके जो कुछ टेस्ट लाइक T2 स्टार MRI या इको या डेक्सा स्कैन जो पिछली बारी जब इन्होंने लास्ट टाइम कराए थे, दे वर अंडर कंट्रोल. तो ऐसे टेस्ट जब तक वेव सेटल नहीं होती या सिचुएशन थोड़ी इजी नहीं हो जाती तब तक पोस्टपोन कर दें. महीना 2 लगता है, फिर उसके बाद फिर करा सकते हैं. बट सर्वेलेंस एंड मॉनिटरिंग शुड कंटिन्यू इवन ड्यूरिंग कोविड टाइम.
Thank you for highlighting that we cannot neglect the other aspects of your medical management, and that goes on. Life has been a challenge for us every single day. It's a little bit more challenging, but everything we must continue as far as possible. Anyway, blood test, you are not, you're going to the hospital for a transfusion anyway. So the next few questions are with regards to transfusion. Dr. Bansal, अब हमारे बहुत सारे बच्चे 30s, 40s में हैं, some of them are 80 kgs. So उनकी blood की requirement ज़्यादा है. एक सिंगल सेशन में कितने यूनिट्स हम दे सकते हैं एंड कितने घंटों में?
राइट, डॉक्टर, तो सवाल है कि हमें ब्लड कितना चढ़ाना है और कितनी देर में चढ़ाना है. तो अगर आपको याद रखना है तो याद रखिए कि जितना थैलेसीमी का वेट है उसको 20 से मल्टीप्लाई करिए. जितना थैलेसीमी का वेट है, बॉडी वेट, उसको 20 से मल्टीप्लाई करिए, उतना ब्लड चढ़ना चाहिए. जैसे कि अगर 10 किलो का वेट है तो 10 × 20 200 ml. अगर 20 किलो का वेट है तो 20 × 20 400 ml पैक्ड रेड सेल्स. तो इतना ब्लड चढ़ना चाहिए. और हमें हमेशा कोशिश करनी है कि अगला ब्लड चढ़ाने से पहले हीमोग्लोबिन अगर आपको याद रखना है 10 ग्राम से ज्यादा होना चाहिए, तभी सब कुछ रेगुलर ठीक चलेगा. तो और जब ब्लड बैंक से हमें ब्लड मिलता है तो जो रूल्स कहते हैं वो 4 घंटे के अंदर अंदर ब्लड खत्म हो जाना चाहिए, क्योंकि अगर हम ब्लड को ज्यादा रखेंगे तो उसमें बैक्टीरिया ग्रो होना शुरू हो जाता है. तो जब ब्लड बैंक से फ्रिज से बाहर निकलता है तो 4 घंटे में यूज हो जाना चाहिए. और ये पहले भी बताया गया है कि उसको रूम यानी कि जब ब्लड हमें ब्लड बैंक से मिलता है उसका टेम्परेचर 1 से 6 डिग्री सेंटीग्रेड होता है. तो जैसे ही मिलता है उसको शुरू किया जा सकता है, उसको गर्म करने की बिल्कुल जरूरत नहीं होती है. तो मतलब कि जैसे ही थैलेसीमिया का पेशेंट 30 kg से ज्यादा हो, यानी कि करीब अप्रोक्सीमेटली 9-10 साल पे बच्चे का वेट 30 किलो हो जाता है, तो उसके बाद से हमें 2 यूनिट चढ़ाने जरूरी हैं. तो ये काफी बारी ऐसे होता है कि लोग ब्लड चढ़ाने की कम कोशिश करते हैं ताकि आयरन ना बढ़े. तो हमें ऐसे बिल्कुल नहीं सोचना. अगला ब्लड चढ़ाने से पहले हीमोग्लोबिन 9.5-10 से ज्यादा ही होना चाहिए. हमें ब्लड से भागना नहीं है और HB को प्रॉपर रखना है. थैंक यू.
Thank you, Dr. Deepak. Just again, there have been many questions to this कि कुछ पेशेंट्स जो सडनली देखते हैं कि 2-3 महीनों से उनकी जो ब्लड वो ले रहे थे रेगुलरली उतना ले रहे हैं, लेकिन हीमोग्लोबिन जैसे आपने कहा 9.5-10 के ऊपर रहना चाहिए, उसकी जगह वो 8, 8.5, 7.5 पे आ रहा है, या और उनको ज्यादा जल्दी ट्रांसफ्यूजन के लिए जाना पड़ता है. सो what should they be looking for when their transfusion requirement has increased in a short span of time and they are unable to maintain the desired hemoglobin?
ये काफी कॉमन क्वेश्चन है कि पेशेंट्स हमें आके बताते हैं कि हमारी ब्लड की रिक्वायरमेंट बढ़ गई है. तो ये थोड़ी टेम्परेरी चीज हो सकती है या लॉन्ग टर्म चीज हो सकती है. टेम्परेरी मतलब कि जैसे कोई भी जुकाम खांसी या कोई भी वायरल इन्फेक्शन हो, टाइफाइड हो जाए, कोई भी इन्फेक्शन हो जाए तो उससे ब्लड कम हो जाता है और ब्लड की रिक्वायरमेंट कुछ हफ्ते या महीने तक बढ़ जाती है। तो फिर हमें ज्यादा चढ़ाना पड़ेगा, वो उसका कोई ऑल्टरनेटिव नहीं है। और फिर कभी कभी ब्लड के अगेंस्ट एंटीबॉडीज बन जाती हैं, जिसे एलो इम्यूनाइजेशन कहते हैं। तो हमें हमेशा जो ब्लड बैंक है उनको रिक्वेस्ट करना है कि सारे जो माइनर ब्लड ग्रुप हैं उनके साथ भी ब्लड हमें मैच करके देना चाहिए। आपको पता होगा कि RH यानी कि पॉजिटिव नेगेटिव मैच होता है, ABO मैच होता है, बट हमें कोशिश करनी चाहिए जो माइनर ब्लड ग्रुप होते हैं जैसे कैल, डफी, किड, S एंटीजन, उनके साथ भी मैचिंग करके देना चाहिए ताकि एंटीबॉडीज ना बने। और कभी कभी फोलिक एसिड की कमी होती है तो हमें रेगुलर फोलिक एसिड लेना है, खासकर अगर HP कम रहता है। पर मैं बोलूंगा जो सबसे ज्यादा कॉमन रीजन है HP कम होने का, वो एक साइकिल बन जाता है कि ब्लड कम चढ़ाओ, उसके कारण स्प्लीन बढ़ जाती है, स्प्लीन बढ़ जाती है तो HB कम रहता है, HB कम रहता है तो और स्प्लीन बढ़ जाती है। तो उसका एक ही तरीका है कि अगले ब्लड से पहले HB 9.5-10 से ज्यादा रखो, ताकि धीरे धीरे स्प्लीन भी अंदर जाने लगे। और वो तभी हो पाएगा अगर हम रेगुलर फटाफट ब्लड चढ़ाएं और HB को 9.5-10 से कभी भी कम ना होने दें। थैंक यू।
Thank you, Dr. Bansal. So it's very important that all patients maintain a chart of their routine pre-transfusion hemoglobin, so that as soon as they see that things are slipping, they can discuss with their treating doctor and get them back on track. Because most of the time, it's that you allow it to go down, the spleen increases. So that, like Dr. Bansal has said, we should not allow to happen. Keep a close eye. Any changes, get in touch with your doctor. Dr. Shruti, this has been highlighted before also, but still we get these questions that do we need to give any pre-medication, or if we are giving 2-3 units of blood, do we need to give any furosemide? या उसके बाद कई बार जैसे बुखार, कंपन के साथ बुखार आता है जिसको हमारे देश में अक्सर लोग मलेरिया से जोड़ते हैं, तो आज की डेट में जिस हिसाब से ब्लड टेस्टेड होता है, क्या रूटीनली एंटी मलेरियल देने की जरूरत है?
थैंक यू डॉक्टर अमिता। सो आई थिंक डॉक्टर दीपक ने जैसे बोला कि आप HP 10 रखिए, 9.5 to 10, दैट इज द बॉटम लाइन, उसको फॉलो करेंगे तो आगे प्रॉब्लम्स नहीं आएंगे। जहाँ तक सवाल है प्री मेडिकेशंस, फ्लूसमाइड, इन चीज़ों की रूटीनली कोई भी ज़रूरत नहीं है। रूटीनली हर थैलेसीमिया के बच्चे को ना तो फ्लूसमाइड की ज़रूरत है, ना किसी एवल पैरासीटामोल की ज़रूरत है। फ्लूसमाइड सिर्फ कुछ कंडीशंस में चाहिए, जैसे सपोज बाय बिकॉज ऑफ सम कॉम्प्लिकेशन या किसी प्रॉब्लम की वजह से बच्चे का HP बहुत कम है, 5 के नीचे आ गया है, तब उस कंडीशन में डॉक्टर डिसाइड कर सकते हैं कि उस ट्रांसफ्यूजन के दौरान बच्चे को एक बार फ्लूसमाइड दिया जा सकता है। या फिर अगर किसी को हार्ट फेलियर है बिकॉज ऑफ आयरन ओवरलोड या किसी प्रॉब्लम की वजह से हार्ट फेलियर की प्रॉब्लम है, बट नॉट एज अ रूटीन, हर बच्चे को फ्लूसमाइड की ज़रूरत नहीं है। और मैम जैसे कि आपने कहा कि आजकल टेस्टिंग होती है, सो मलेरिया आप सब जानते हैं जब ब्लड बैंक से इशू होता है तो 6 चीज़ों के लिए टेस्ट होके आता है, जिसमें हेपेटाइटिस B, C, HIV 1 and 2, सिफिलिस एंड मलेरिया इंक्लूडेड होते हैं। एंड यूजली जो ये कार्ड टेस्ट होते हैं इनकी जो सेंसिटिविटी है वो 95% है। सो किसी भी थैलेसीमिया पेशेंट को ट्रांसफ्यूजन के साथ में रूटीनली एंटी मलेरियल लेने की, क्लोरोक्विन लेने की कोई ज़रूरत नहीं है। अगर आपको फीवर है, चिल्स है, प्लीज अपने डॉक्टर को कांटेक्ट करिए एंड लेट देम डिसाइड व्हाट इज बेस्ट फॉर यू।
थैंक यू। Professor Porter, some of our units have struggled to get voluntary blood donations during this last year when COVID peaks have been very high, because a lot of hospitals are entirely dependent on voluntary blood donation. How many days, generally blood banks in India do cooperate that give us the freshest possible blood for our thalassemic patients. But if there is a constraint, how many days old blood can be given for patients who have thalassemia?
Yeah, so this is under review, and I think the guidelines have changed in the up and coming version. It's a bit more permissive. I think my observation has been in India, because of the way things are organized, often very fresh blood is given because you get the donor along on the same day, which is great. And historically, we've always tried to give blood which is, no more than 2-3 days old. That is getting harder. And actually the evidence that provided blood is less than 2 weeks old, that's disadvantageous. He's not very strong. So we're allowing blood up to 2 weeks old. Although it's not our intention to do it, we allow it if that's the only blood we can give.
Thank you. So कई पेशेंट्स बहुत अपसेट होते हैं आजकल क्योंकि उनका जो ब्लड है वो 1 हफ्ता 10 दिन पुराना है, तो उसमें बिल्कुल भी कोई इशू नहीं है. करंट गाइडलाइंस भी यही रेकमेंड करती हैं कि अप टिल 2 वीक्स ओल्ड ब्लड हम सेफली दे सकते हैं, उससे कोई ट्रांसफ्यूजन रिक्वायरमेंट इंक्रीज नहीं होगी. Dr. Khanna, this question again keeps coming up. What are the indications of using washed packed red cells? Are they better than the leukodepleted blood that we give?
Washed red cells are indicated only in 2-3 conditions, like when there are history of severe allergic reactions, then we should give them washed red cells. और एक खास कंडीशन होती है जिसको हम बोलते हैं इम्यूनोग्लोबुलिन ए, IgA डेफिशिएंसी, उसमें जो होती है washed red cells देने चाहिए पेशेंट को. अदरवाइज देर रूटीनली देने की कोई जरूरत नहीं होती क्योंकि ओपन मेथड है और भी कई रिस्क होते हैं इसके. और जहां तक माइल्ड एलर्जिक ट्रांसफ्यूजन रिएक्शंस होते हैं, दोज वी कैन कंट्रोल बाय गिविंग एंटीहिस्टामिन्स और स्टेरॉइड्स.
थैंक यू.
सो मेन वही है.
थैंक यू. Professor Porter, it's been a common observation of many patients that when they are reaching or approaching the next transfusion, they start developing backache. And even if they are optimally transfused, so it's not necessarily. So, do you see this problem, and what is the explanation, and how could we make them feel better?
Yes, we do see the problem. I would say we see it in about 20% of patients. The explanation is expansion of the bone marrow. The bone marrow is becoming active in that area and is causing pain as it remodels in a fairly acute sense. What do we do about it? We offer a more intensive transfusion regime. So if, for example, their pre-transfusion hemoglobin was hitherto 8.5 to 9.5 or 9.5 to 10.5, we would put it up a gram. So if it was 9.5 to 10.5, we will put it 10.5 to 11.5 and see if it helps. And it usually does help, actually. The other approach is to bring the transfusions closer together. So if they've been on 4 weekly transfusions, we make it to 3 weekly or 2 weekly. But that is more intrusive on the patient's lifestyle. So we generally keep the pre-transfusion hemoglobin higher by giving more blood, although we can bring the transfusions closer together.
Could hydroxyurea help, to suppress the extramedullary or medullary hematopoiesis?
Yeah, I think in principle it could, and we have done it. The thing is that actually the pain pre-transfusion is dramatically changed by changing the transfusion regime. So, but yes, it could well help as well.
And for patients who have alloimmunization, because most centers in India are not able to, do extended phenotype matched, blood transfusions, and patients, we do encounter alloimmunization in a significant proportion. So what is your, other than, trying to match and give them as best matched blood as possible, how do we medically manage alloimmunization?
Well, that's a huge issue and a huge question. Obviously, the best thing is to avoid it in the first place. And the way to do that is to give blood which is as near to phenotype matched as is logistically possible. Of course, it's not possible to give blood which is more than rhesus and Kell typed, but we do that. So we give rhesus and Kell type blood. If a patient has developed, say, a Duffy as well, then the worry is that they're more likely to develop other alloantibodies, and we would have a discussion as to looking at that patient's genotype. We get everybody genotype now. It's very difficult to do it other than by DNA when they're being transfused. And we would see what's going to be possible going forward. But we would recognize it if an adult say, at age 25, who's never had an alloantibodies before, develops a new alloantibody, and it's against a common antigen, you have to ask the question, why? And is it going to happen again? And what can you try to do to reduce further alloimmunization? So what you need then to do is look at the full genotype and see what is going to be possible to avoid logistically. But it's often not possible to get, what you really want, and you just have to do the best you possibly can. Now, I suppose a link to that question is, would you routinely give, for example, IVIG with the transfusion or steroids? I think we would not, except we have done in some patients. Some of the sickle cell patients are a huge problem. We're getting this syndrome of hyperhemolysis. I don't know if you've been seeing this in India at all in the thalassemia patients. In sickle, we see, we must have about 20 patients in London, maybe more, who have hyperhemolysis. That is to say, they hemolyze everything you give them in the absence of demonstrable alloantibodies. And it's very, very difficult to manage. And I don't have an answer, except we've given eculizumab to some patients, but the experience is quite small, and we give IVIG to cover the transfusions under those circumstances.
So, जैसा डॉक्टर पोर्टर ने हाईलाइट किया कि एलो इम्यूनाइजेशन या एंटीबॉडी आ जाना एक मेजर चैलेंज है, तो हम लोग भी, जैसे उन्होंने कहा है, कुछ दवाइयों से जहां तक हो सकता है कि बेस्ट ब्लड को माइनर एंटीजन से मैच करके देने की कोशिश करते हैं, और कुछ ऐसी दवाइयां जैसे कई बार स्टीरॉइड्स, आईवीआईजी, एजोरैन या इवन रिटक्सिमैब भी इसमें हमने यूज की हैं, बट वो इंडिविजुअल पेशेंट में ही डिसाइड किया जाता है कि कैसे उस पेशेंट को बेस्ट मैनेज किया जा सकता है। अब अगले कुछ सवाल हैं कीलेशन को लेके। डॉक्टर बंसल, we now have 3 chelators available to us. Most patients are managing good control of their iron overload, पर what is the, कितना फेरेटिन के लिए हमें टारगेट करना है, या और ऐसा कोई लेवल है जिसके नीचे आने पे हमें दवाई बंद करनी है?
फेरेटिन सारे पेशेंट्स रेगुलर बेसिस पे करवाते हैं, तो अगर एक मोटा मोटा नंबर याद रखना है तो कोशिश हमें ये करनी चाहिए कि 1000 से कम फेरेटिन रहे। 1000 सीरम फेरेटिन हमें टारगेट करना होता है। और कई पेशेंट्स जो बहुत ज्यादा रेगुलर और ठीक से दवाई लेते हैं, उनका फेरेटिन फिर धीरे धीरे और भी कम होने लग जाता है। तो टिपिकली ये बोला जाता है कि जैसे अगर 500 हो जाए, 500 हो जाए, तो दवाई प्रेफरेबली बंद नहीं करनी चाहिए, डोज कम कर देनी चाहिए, क्योंकि अगला ब्लड फिर आ जाएगा, फिर बढ़ जाएगा। तो टिपिकली ऑल्दो ज्यादातर पेशेंट्स में हो नहीं पाता, बट हमें कोशिश करनी चाहिए कि फेरेटिन 1000 से कम रहे। और अगर पूरे सेशन में अगर आपको 2 चीजें याद रखनी है, तो थैलेसीमिया के मेनली 2 रूल्स होते हैं। अगला ब्लड चढ़ने से पहले HB 10 से ज्यादा रहे और सीरम फेरेटिन 1000 से कम रहे। और अगर ये 2 रूल फॉलो होते हैं तो ज्यादातर कॉम्प्लिकेशंस अवॉइड हो जाएंगे। थैंक यू।
थैंक यू। डॉक्टर श्रुति, अभी कोविड-19 से अगर पेशेंट संक्रमित है या इन्फेक्टेड है और एक्चुअली अभी क्वारंटीन में है या स्मॉल प्रोपोर्शन अगर हो, तो उनको उस दौरान के लिए क्या किलेशन को, स्पेशली डेफ्रासिरॉक्स पे, क्योंकि ज्यादातर लोग अब डेजीरॉक्स या उस पे हैं, तो उनको क्या बंद करना जरूरी है या क्या करना चाहिए?
Ma'am, I think I would like to share my experience. This happened with one of our patients who had, thalassemia, severe iron overload, and diabetes and HIV. So all this combination, and he was the first one in the unit to get COVID-19. उसको मतलब पहला patient last year April, जबकि हम समझ रहे थे अभी COVID को, patient को COVID हुआ, he was admitted in the hospital because सारे comorbidities थे उनको, and we stopped chelation for 15 to 20 days. 1 महीने बाद the patient came back to us with cardiac failure. So we learned this by the wrong way. So इससे हमें यही सीख मिलती है कि बिल्कुल chelation बंद नहीं करना चाहिए। Unless and until आपको severe COVID है, आप admitted हैं ICU में, don't stop your chelation. Especially mild cases, there is no need to stop your chelation. अपनी दवाइयाँ time से लेते रहिए।
Thank you for reiterating that. Dr. Khanna,
Could I comment on that? Maybe. So I agree with you completely. When a thalassemia patient gets an infection, there is a little bit of a knee-jerk response in quite a lot of the junior doctors and even some of the senior doctors, oh, we have to stop chelation because it might be Yersinia or something like that. I think the risks of stopping are probably greater than the risks of continuing. And obviously, if it does look like Yersinia or you've got overwhelming Klebsiella or something, but the problem is, you know, when you're septic, you're generating non-transferrin bound iron. You've got a lot of toxic iron sloshing around, and actually that's when you need your chelation. So you've got to make a clinical judgment, and it shouldn't be a reflex infection, stop. No, that's not right.
Thank you for highlighting it again, Dr. Porter. So we need to continue our chelation unless your doctor specifically tells you to. Sure. Dr. Khanna, in India, we have so many brands. जो इनोवेटर प्रोडक्ट हैं वो भी मिलते हैं, बहुत सारी इंडियन ब्रांड्स भी हैं. सो पेशेंट्स कैसे चूज करें कि हमें क्या ये सही है, प्राइस डिफरेंस बहुत सिग्निफिकेंट है, तो आप क्या उनको सलाह देते हैं?
मेरे हिसाब में ऑल आर इक्वली इफेक्टिव. कोई ऐसा ब्रांड का कोई प्रेफरेंस नहीं है हमारे दिमाग में. किलेशन लेनी बहुत जरूरी है और रेगुलरली लेनी बहुत जरूरी है. कोई भी ब्रांड ले लें, कोई प्रॉब्लम नहीं है. कुछ लोग ठीक है महंगी ब्रांड को पसंद करते हैं, कुछ ये वाला ब्रांड पर कोई लोग अफोर्ड नहीं कर पाते. उसका कोई भी नहीं है. जो ब्रांड अवेलेबल आप लेना चाहते हैं वो ले लीजिए. दे आर ऑल इक्वली इफेक्टिव. आई नो.
सो सारी ब्रांड्स जो इंडिया में हैं वो DCGI या ड्रग कंट्रोलर अथॉरिटी से अप्रूव्ड है. कोई किसी को अभी तक कोई कंसर्न्स ऐसे हाईलाइट नहीं हुए. तो जैसे डॉक्टर खन्ना ने कहा, द नेम डजंट मैटर, you need to take it and you need to take it regularly. That is what is most important. Now we come to the next section, which is, which is a major issue for us, for most of our growing patients. And I would now like to invite Dr. Anju. We've tried to do it in a way that Dr. Anju एक साथ सारे सवाल जो आप लोगों ने भेजे हैं उनको ले सके. तो Dr. Anju, thank you so much for joining us. So
thank you, Dr. Amita. नमस्कार फ्रेंड्स.
So सबसे पहला क्वेश्चन, क्योंकि हम 10 साल के बाद सब बच्चों को बोलते हैं कि आपको बाकी टेस्ट के साथ साथ शुगर का टेस्ट भी करना है. So what is the best test? क्योंकि कई बार बताया जाता है कि HB1 A1C बढ़ा हुआ आ सकता है क्योंकि आपको ग्लाइकोसिलेटेड ब्लड मिला है, तो या फ्रक्टोसमीन या ग्लूकोज टॉलरेंट टेस्ट. तो आप हमें क्या सुझाव देंगे कि हमें ग्लूकोज के लिए क्या टेस्ट करना चाहिए?
देखिए, अगर हमें ब्लड शुगर की स्क्रीनिंग करनी है कि बच्चे को डायबिटीज होने की संभावना है या वो डायबिटीज में जा रहा है, एक सरल टेस्ट है फास्टिंग ब्लड शुगर. तो जब हम बच्चों का एक एनुअल एंडोक्राइन स्क्रीनिंग करते हैं, उसमें एक सिंपल टेस्ट ये इंक्लूड करते हैं फास्टिंग ब्लड शुगर. फास्टिंग माने रात को कम से कम 8 घंटे का फास्ट. एंड सिंपल फास्टिंग ब्लड शुगर काफी है हमारे लिए. सिर्फ उन्हीं बच्चों में जिसमें हम कहते हैं इम्पेयर्ड ग्लूकोज, फास्टिंग ग्लूकोज, यानी फास्टिंग ग्लूकोज अगर 100 और 125 के बीच में आता है, उसी हालत में हम आगे टेस्ट करते हैं जिसे ग्लूकोज टॉलरेंस टेस्ट कहते हैं. इतना ही काफी है स्क्रीनिंग के लिए.
तो HbA1c, क्योंकि कई बार अब लैब्स जो है रूटीन में उनके पैकेज में हर इंसान के लिए कर देती हैं, तो उसको क्या वो फॉल्स मिसलीडिंग हो सकता है?
वो मिसलीडिंग हो सकता है. इवन जो थैलेसीमिया के बच्चे जिनको डायबिटीज हो जाता है, उनमें भी हम HbA1c से नहीं मॉनिटर कर सकते. कारण यह है कि हम हर 3 हफ्ते में उन्हें ब्लड ट्रांसफ्यूजन दे रहे हैं, और जो HbA1c है वो एक तरह से लॉन्ग टर्म कंट्रोल दिखाता है पिछले करीबन 3 महीने का, और उसमें कई बार ट्रांसफ्यूजन होंगे, तो वो रिफ्लेक्शन सही हो ही नहीं सकता है. तो उसका कोई फायदा नहीं है, वो मिसलीडिंग है. So fasting blood sugar is a good test.
And fructosamine, जिनको ऑलरेडी डायबिटीज है, उनकी मॉनिटरिंग के लिए क्या यूज करें?
फ्रक्टोसामीन को उस हालत में यूज किया जा सकता है, लेकिन डिपेंड करता है. उसमें भी देखिए, जो थैलेसीमिया में डायबिटीज है वो टाइप 1 और टाइप 2 डायबिटीज दोनों से थोड़ा अलग है. तो शुरुआत में अक्सर उनमें इंसुलिन रेजिस्टेंस होता है, यानी इंसुलिन की कमी नहीं है, इंसुलिन काम नहीं कर रहा. तो ऐसे सिचुएशन में हम ओरल ड्रग्स देते हैं, पर धीरे धीरे जैसे पैनक्रियास पर ज्यादा असर होता है आयरन टॉक्सिसिटी का, उनमें इंसुलिन की कमी आ जाती है, तो बाद में उन्हें इंसुलिन रिक्वायरमेंट हो जाती है. तो हमारी मॉनिटरिंग की जो रिक्वायरमेंट्स हैं वो भी थोड़ी चेंज होती रहती हैं डिपेंडिंग ऑन पेशेंट ओरल ड्रग्स पर है या इंसुलिन पर है, तो जो पेशेंट इंसुलिन पर है तो हम उसमें ज्यादा इंटेंसिव मॉनिटरिंग करते हैं, मल्टीपल ब्लड शुगर लेवल्स इन ए डे करते हैं। जब तक वो ओरल हाइपोग्लाइसीमिक्स पर है, फास्टिंग शुगर एंड समटाइम्स प्री मील ब्लड शुगर्स काफी रहते हैं तो असेस ओवरऑल कंट्रोल।
अब बहुत सारे कई पेशेंट्स ने हमारा पूछा है जिनके शायद डायबिटीज अभी ही डायग्नोज हुई है, देयर मे हैव बीन लैप्सेस इन ऑप्टिमल कंट्रोल ऑफ कीलेशन, तो एक बार उनको झटका सा लगता है कि मैं क्या हम अगर अभी कमर बांध के कमर कस के इंटेंसिव कीलेशन करें तो क्या ऐसा पॉसिबल है कि हमें इससे पीछा छूट जाए?
हाँ, ये एक कमर कसना तो अच्छी बात है, पर हमारे पेशेंट ज्यादा देर कमर कसते नहीं है। प्रॉब्लम सारी वहाँ आती है 2-3 दिन में वो झटका जरूर लगता है उनको, फिर वो बहुत कुछ एक्सेप्ट कर लेते हैं। अनफॉर्चुनेटली ये सही नहीं है। तो आपने बिल्कुल सही कहा, एक तरह से वेकअप कॉल है। अगर आपके, क्योंकि हमारे पास डायबिटीज अचानक से नहीं हो जाता है, अगर हम स्क्रीनिंग कर रहे हैं तो शुरुआत में इम्पेयर्ड फास्टिंग ग्लूकोज होगा, उसके बाद में इम्पेयर्ड ग्लूकोज टॉलरेंस होगा, उसके बाद में जाके फ्रैंक डायबिटीज होता है। तो हमारे पास विंडो है कंट्रोल करने के लिए, एंड ये टाइम है फॉर ए वेकअप कॉल। उससे हम खाली डायबिटीज ही नहीं, बाकी की भी कॉम्प्लिकेशन, चाहे वो कार्डियक है, चाहे हेपेटिक है, या बाकी के एंडोक्राइन कॉम्प्लिकेशन है, उन्हें भी काफी हद तक डिले तो कर ही सकते हैं। सो डेफिनेटली इट्स ए वेकअप कॉल, and if we go in for a intensive chelation, it is possible to control it there and then. and उसके बाद में भी दवाइयों की जरूरत तो काफी बाद में पड़ती है। लाइफस्टाइल चेंजेस जो हम सिंपल टाइप 2 डायबिटिक्स में बताते हैं, which just means basically a healthy diet, एंड डायबिटिक डाइट कोई बहुत खराब डाइट नहीं होती है, हेल्दी डाइट है वो, हम सबको वही डाइट लेनी चाहिए। एक हेल्दी डाइट और एक फिजिकली एक्टिव लाइफस्टाइल बहुत हद तक मदद कर सकता है along with the intensive chelation to at least delay the progress of diabetes.
Thank you for such a positive overview. तो सबको यही हमें सीख लेनी है कि पहले तो हम यहाँ तक नौबत आनी नहीं चाहिए, पर अगर किसी वजह से या डिस्पाइट एडिक्वेट मेडिकल मैनेजमेंट भी ऐसा हो जाता है, तो इफ वी आर वेरी एक्टिव अबाउट दिस, इसमें हमें इससे बहुत बेनिफिट मिल सकता है, रादर देन कि हम डिसहार्टन होके कि अब क्या फायदा है। वो अप्रोच ना लेने की बजाय वी नीड टू टेक अ पॉजिटिव अप्रोच, बिकॉज जैसे डॉक्टर अंजू ने कहा, बहुत एक्टिव मैनेजमेंट से हम बहुत कुछ अचीव कर सकते हैं, ना केवल डायबिटीज के लिए बल्कि जो और बाकी ऑर्गन सिस्टम्स बॉडी में हैं। डॉक्टर अंजू, ये कैल्शियम की कितनी जरूरत है इनको? क्या सब बच्चों को बहुत छोटी उम्र से कैल्शियम देना चाहिए? विटामिन D3 कितनी मात्रा में हमें इन्हें देना चाहिए?
हाँ, ये इम्पोर्टेंट सवाल है। देखिए, सबसे पहले हम अगर थैलेसीमिया के बियॉन्ड भी जाएं, सब बच्चों को डाइटरी कैल्शियम एक एडिक्वेट मात्रा में लेना चाहिए, चाहे थैलेसीमिया है या नहीं है। और वो एडिक्वेट मात्रा क्या है? 500 मिलीग्राम पर डे कैल्शियम से लेकर के करीबन एडोलेसेंस में, किशोरावस्था में जब उनकी बोन्स बहुत तेजी से बढ़ रही हैं, मे बी अप टू 800 to 1000 मिलीग्राम पर डे कैल्शियम लेना है। इतना कैल्शियम हमें कहाँ से मिलता है? एक अंदाजा अगर मैं दूं, सो जैसे काउज मिल्क है, हर 100 ग्राम काउज मिल्क में 100 ml में करीबन 120 मिलीग्राम कैल्शियम है। विच मीन्स अगर हम दिन भर में 500 ग्राम के करीब काउज मिल्क या उससे बने प्रोडक्ट्स, चाहे वो दही है चाहे पनीर है, वो ले रहे हैं, तो उससे मोटे मोटे हमारी कैल्शियम रिक्वायरमेंट मैच हो जाती है। बट द फैक्ट इज, इंडिया में थैलेसीमिया या बियॉन्ड थैलेसीमिया बच्चों का कैल्शियम इंटेक कम है। क्या वजह है? काफी लोग अफोर्ड नहीं कर पाते आज की डेट में भी इतना मिल्क अपने बच्चों को देना। अनफॉर्चुनेटली जो अफोर्ड कर सकते हैं वो लेना चाहते नहीं है, उन्हें पसंद ही नहीं है दूध। सो ये सब बच्चों को, एंड थैलेसीमिक्स आर नो एक्सेप्शन, दे नीड दिस मच कैल्शियम। और एक चीज हमें याद रखनी पड़ेगी, बच्चे जो थैलेसीमिया वाले हैं, देर एनीवे मोर प्रोन टू पुअर बोन हेल्थ। और ये कैल्शियम, हम आगे भी इसकी बात करेंगे, और विटामिन डी एक पोटेंशियली मॉडिफाइबल फैक्टर है जो हमारे हाथ में है। तो इट मेक सेंस टू हैव ए ऑप्टिमल इनटेक ऑफ कैल्शियम एंड विटामिन डी। सप्लीमेंट लेना जरूरी नहीं है, यू इंश्योर इट फ्रॉम द डाइट, इट इज प्रीटी गुड। पर अगर आप डाइट के बजाय गोलियों में विश्वास करते हैं, देन प्लीज गो अहेड एंड टेक कैल्शियम सप्लीमेंट। अगर दूध नहीं लेना, बहुत ही जिद करनी है, हमें अपनी डाइट नहीं ठीक करनी, गो अहेड एंड टेक कैल्शियम। एंड यस, विटामिन डी सप्लीमेंटेशन वुड बी इंपॉर्टेंट टू मेंटेन इट इन ए नॉर्मल रेंज, क्योंकि डाइटरी विटामिन डी कम होता है। एंड उस हालात में हमें करीबन 600 to 800 international units vitamin D every day at least during adolescence and 600 during childhood हमें देना चाहिए, अगर हम उसे डाइट से। अभी आजकल फूड फोर्टिफिकेशन शुरू हो गया है इंडिया में, एंड मिल्क का फोर्टिफिकेशन हो गया है, पर जब तक ये सारी पॉपुलेशन तक नहीं पहुंच पाता थ्रू फूड फोर्टिफिकेशन, अगेन इंपॉर्टेंट ये है हम किसी भी तरह से एडिक्वेट अमाउंट ऑफ कैल्शियम और विटामिन डी दें। अगर डाइट से नहीं जा रहा है तो सप्लीमेंट।
थैंक यू
डॉक्टर अमिता, अगर मैं डॉक्टर अंजू से पूछना चाहूँ कि शुड विटामिन डी बी गिवन एज ए कैल्शियम टैबलेट एवरी डे और शुड वी गिव इट एज ए सैशे एवरी मंथ और एवरी ऑल्टरनेट मंथ, because I think most thalassemics are getting daily calcium D3 tablets as well as sachet every month, so which is better?
एक्चुअली डॉक्टर दीपक दोनों नहीं देने हैं हमें। वी ऑल्सो हैव टू बी अवेयर दैट विटामिन डी भी एक दवाई है, उसकी टॉक्सिसिटी होती है। सो इररिस्पॉन्सिबल एडमिनिस्ट्रेशन ऑफ एनी ड्रग, एंड इंडिया में अनफॉर्चुनेटली ये दवाइयाँ अक्रॉस द काउंटर मिल जाती हैं। सो और जो हमारे सैशेज आते हैं 60,000 का सैशे है, राइट? सो वो 60,000 का सैशे पर मंथ भी ले और डेली कैल्शियम भी ले विदाउट मॉनिटरिंग, दैट्स नॉट ए गुड आइडिया। You can end up having toxicity and that's not going to help the bone health. Either would be okay, but जो हमारी नॉर्मल कैल्शियम की टैबलेट्स आती हैं उनमें डॉक्टर दीपक विटामिन डी यूजुअली इतना नहीं होता है। बहुत सारी फॉर्मुलेशंस हैं एंड मोस्ट ऑफ देम जिसमें कैल्शियम ज्यादा है उसमें विटामिन डी उतना नहीं होता कि डेली रिक्वायरमेंट मिल जाए। सो आई वुड एक्चुअली से हैव ए गुड डाइट जिसमें कैल्शियम आपको मिल जाए एंड यू कैन टेक मंथली विटामिन डी। हैविंग सेड दैट थैलेसीमिक्स में ऐसी कोई स्पेसिफिक स्टडीज नहीं हुई हैं, बट वी डू हैव लॉट ऑफ स्टडीज इन चिल्ड्रन। एनीथिंग विल डू, पर जहां पर भी हम मेजर बिग डोजेस दे रहे हैं ना, इट मेक सेंस दैट बीच बीच में हम पीरियोडिकली उनका 25 हाइड्रोक्सी विटामिन डी मॉनिटर कर लें, सो दैट जस्ट टू सी कि हम उसे मेंटेन कर रहे हैं नॉर्मल रेंज में। वी कैन यूज ईदर अप्रोच।
थैंक यू डॉक्टर अंजू, डिलेड प्यूबर्टी बड़ी कॉमन प्रॉब्लम है, कई सारे उसके रीजन हैं। सो पेशेंट्स और बहुत सारे सेंटर्स में पेशेंट्स जो हैं ट्रांसफ्यूजन सेंटर पे जाते हैं, ले लेते हैं, डॉक्टर्स के पास वो 6 महीने या साल में पहुंचते हैं। सो किस एज से उनको होना चाहिए कि हमें अभी प्यूबर्टी की मॉनिटरिंग जरूरी है, और किस एज से किस फ्रीक्वेंसी पे वो स्पेशली इस इशू के लिए अपने डॉक्टर को के पास जाएं?
प्यूबर्टी की मॉनिटरिंग एक तरह से एक कॉम्प्रिहेंसिव एंडोक्राइन स्क्रीनिंग का एक इम्पॉर्टेंट पार्ट है। सो हम तो ये सजेस्ट करते हैं कि जो ग्रोथ मॉनिटरिंग है, सिंपल प्लॉटिंग ऑफ वेट एंड हाइट, वो तो जब से बच्चा आपके क्लिनिक में आ रहा है उसका ग्रोथ चार्ट बना लीजिए। एंड एक जो ग्रोथ चार्ट है एक बड़ा रोबस्ट तरीका है जानने का बच्चे की ओवरऑल हेल्थ कैसी है, कब उसकी हाइट डिविएट कर रही है। इसी प्रकार जब वो बच्चा करीबन 9-10 साल का हो जाता है, द मैजिक फिगर इज 9 to 10 years, उसके बाद से आपको उसकी एनुअल एंडोक्राइन स्क्रीनिंग करनी है, जिसमें आपको प्यूबर्टी की भी स्क्रीनिंग करनी है। सिंपल फिजिकल एग्जामिनेशन से हो जाती है, कोई टेस्ट की जरूरत नहीं है। अगर गर्ल्स में ब्रेस्ट डेवलपमेंट पहला साइन है और एक फिजिशियन आराम से वो कर सकता है एट ए टाइम, जब बच्चा आपके पास हर महीने आ रहा है ट्रांसफ्यूजन के लिए, उससे भी फ्रीक्वेंटली। सो एंड बॉयज में टेस्टिस की एनलार्जमेंट, ये दो चीजें बहुत ही एक सिंपल फिजिकल साइन है जिसको हम क्लिनिकली देख सकते हैं। एंड व्हाट वी एक्सपेक्ट इज नॉर्मली प्यूबर्टी के स्टेजेस बड़े अच्छे से वेल डिस्क्राइब्ड हैं, एंड वी एक्सपेक्ट कि बच्चा एक स्टेज ऑफ प्यूबर्टी से दूसरी स्टेज में करीबन 1 साल भर में तो शिफ्ट करेगा ही। तो व्हाट एज डॉक्टर्स हम कर सकते हैं कि वो शुरू कब हुई। एक आम बच्चे में, लड़कियों में, इन ए हेल्दी चाइल्ड 9 से 11 साल की उम्र में अक्सर प्यूबर्टी की शुरुआत हो जाती है, और लड़कों में 11 से 12 साल के बीच में थोड़ी रेंज होती है, थोड़ी किसी में पहले किसी में थोड़ी सी बाद में। अगर किसी लड़की में शुरुआत 13 साल की उम्र तक नहीं होती है, शुरुआत हो ब्रेस्ट डेवलपमेंट वो, और इसी प्रकार लड़कों में 14 साल आमतौर पर, क्योंकि लड़कों में थोड़ा लेट होता है लड़कियों से, लड़कों में अगर 14 साल तक नहीं होती है टेस्टिकुलर एनलार्जमेंट, तो हम कह सकते हैं ये डिलेड है। तो ये टाइम है उसका वर्कअप करने की। सो हमें खाली शुरुआत ही नहीं देखनी है, जिसकी शुरुआत टाइम से हो गई है हमें उसकी प्रोग्रेस भी देखनी है। तो हर स्टेज ये नहीं कि एक बार शुरू हो गया तो वी कैन रेस्ट प्रिटी। बहुत से अलग अलग पैटर्न्स देखे हैं। कई बार बच्चों का लेट शुरू होता है पर चल पड़ता है, किसी का शुरू हो जाता है और रास्ते में ही अटक जाता है, उसे हम प्यूबर्टल अरेस्ट कहते हैं। तो वी हैव टू कीप मॉनिटरिंग ऑल्सो कि हर साल में वो प्रोग्रेस कर रहा है कि नहीं। एनुअल फॉलोअप इज ग्रेट। सो वी स्टार्ट इंटरवेंशन when it is delayed beyond 13 years in girls or 14 years in boys, but we keep monitoring even in those who are progressing.
Thank you. अब जैसे आपने कुछ बच्चों में जब स्पॉन्टेनियस, स्पेशली अगर आयरन ओवरलोड बहुत अच्छे से मैनेज नहीं है, प्यूबर्टी बहुत लेट होती है, तो एंडोक्रिनोलॉजिस्ट की गाइडेंस से हम लोग उनको शुरू में सेंसिटाइजिंग और अगर जरूरत पड़ती है तो रिप्लेसमेंट हार्मोनल ट्रीटमेंट देते हैं आप लोगों की गाइडेंस से। अब कुछ बहुत ये सवाल आया कि कुछ लोग जो 40s में हैं, 50s में हैं, एक नेचुरल मेनोपॉज की एज भी अब उनकी आ रही है, तो उन्हें क्या, और ये मुझे बहुत अच्छा लगा ये सवाल कि आज हम मेनोपॉज की बात कर रहे हैं, दिस हैज कम फ्रॉम द पेरेंट्स, सो इट वाज एक्चुअली अ हार्टनिंग क्वेश्चन टू एड्रेस। तो किस एज तक उनको ये लेना है कि अब हम इन्हें मेनोपॉज दे सकते हैं? ये जो दवाई हम देते हैं, चाहे सस्टेनॉन दें या कुछ और दें, तो उसके क्या कोई साइड इफेक्ट्स हैं या सिर्फ ये रिप्लेसमेंट है? और कई एंडोक्रिनोलॉजिस्ट सजेस्ट करते हैं कि सस्टेनॉन से पहले हम कुछ समय अगर दे सकें तो HCG दें। तो ये जो रिप्लेसमेंट थेरेपी के अराउंड कुछ पेशेंट्स के सवाल हैं, अगर आप क्लैरिफाई करें तो।
थोड़े दो पार्ट्स में करते हैं, क्योंकि जो HCG का रोल है, मैं क्योंकि एक पीडियाट्रिशियन हूँ, मैं अपना एरिया की पहले बात करूंगी बिफोर गोइंग इनटू द नेक्स्ट एरिया। सो पहले ये बात करें कि HRT की, आपने ठीक बोला कि हम लोग शुरू करते हैं जो, अगर हमारे पास बच्चे रिलेटिवली जल्दी आ जाते हैं, से 14-15 साल की उम्र तक, तो वो एक टाइम है अगर उनकी तब तक प्यूबर्टल डेवलपमेंट स्टार्ट नहीं हुई, हम एक सेंसिटाइजिंग डोज दे सकते हैं। सेंसिटाइजिंग डोज क्या है? टेस्टोस्टेरोन फॉर बॉयज, ईस्ट्रोजन फॉर गर्ल्स, लो डोज फॉर ए फ्यू मंथ्स दे करके उसे हम कहते हैं जंप स्टार्ट करना प्यूबर्टी को। सो दैट कैन हेल्प स्टार्ट प्यूबर्टी जिसमें होने वाली थी लेकिन डिले हो रही है। सो काफी बच्चों में जो डिलेड प्यूबर्टी होती है, हम इस प्रकार का कुछ महीने का सपोर्ट दें और उसके बाद में विड्रॉ करें और फॉलो अप करें, तो उन्हें आगे कंटिन्यू करने की जरूरत नहीं है। उनकी प्यूबर्टी अपने आप से चल पड़ती है, पर मॉनिटर हमें करना पड़ता है कि वो ठीक से प्रोग्रेस कर रही है। लेकिन अक्सर हमारे पास अभी भी पेशेंट्स बहुत लेट आते हैं। सो इफ आई हैव अ 16-year-old और 17-year-old कमिंग एट दैट स्टेज, लड़की को 16 साल से ऊपर हो गए, उसे पीरियड स्टार्ट ही नहीं हुए, या कभी स्टार्ट हुए और अभी पिछले 1 साल 2 से हो ही नहीं रहे हैं पीरियड्स। सिमिलरली अगर बॉयज में अगर उस वक्त तक भी कुछ भी डेवलपमेंट नहीं हुआ है, उन बच्चों में अक्सर हमने देखा है वो स्टॉप करने का फायदा होता नहीं है। तो उनको एक, तो जो प्यूबर्टल अरेस्ट में है या प्यूबर्टल फेलियर में है, उनमें अक्सर हमें लाइफ लॉन्ग देना पड़ता है। और वो मैं आऊंगी, आपने जो सवाल रेज किया, बट बिफोर दैट साइड इफेक्ट्स। तो साइड इफेक्ट्स जब हम बच्चे को शुरुआत करते हैं हार्मोन रिप्लेसमेंट की, वी हैव टू बिल्ड इट अप स्लोली। एक नॉर्मल जैसे होता है, बच्चा जब प्यूबर्टी से जाता है धीरे धीरे उसके हार्मोन्स बढ़ते हैं, हमें वही मिमिक करना होता है। अगर हम वो ना करें और उसको हाई डोज में शुरू में दे दें, दैट कैन क्रिएट ट्रबल एंड दैट कैन लीड टू साइड इफेक्ट्स। Therefore, ये जो प्यूबर्टल इंडक्शन है, ये केयरफुली एक एंडोक्राइनोलॉजिस्ट के केयर में होना चाहिए, अदरवाइज इट कैन क्रिएट ट्रबल। फॉर एग्जाम्पल, हमने ये देखा है गर्ल्स में, अगर आप ईस्ट्रोजन्स बहुत जल्दी दे दें, बहुत ज्यादा दे दें, तो ब्रेस्ट की जो मॉर्फोलॉजी है, जो उसकी शेप है, वो नॉर्मल ब्रेस्ट से थोड़ी अलग हो जाती है, विच कैन बी डिस्ट्रेसिंग टू ए पर्सन। इसी प्रकार बॉयज में अगर हम टेस्टोस्टेरोन का ज्यादा डोज दे दें, तो पिनाइल रेडनेस या उसमें इरेक्शन की प्रॉब्लम आ सकती है, जो फिर डिस्ट्रेसिंग होता है पेशेंट के लिए। अगर हम उसे मॉनिटर करके इंक्रीमेंटल डोजेज में बढ़ाएं, तो ये मेडिसिन सेफ हैं और उनको दिया जा सकता है। आजकल गर्ल्स के लिए भी जो ड्रग्स आ रही हैं, मोस्टली आर लो ईस्ट्रोजन पिल्स, तो जो उनकी लॉन्ग टर्म कॉम्प्लिकेशंस हैं, लाइक इंक्रीज प्रेडिक्शन फॉर वीनस साइनस थ्रोम्बोसिस, वो काफी हद तक कम हो जाते हैं। आई वोंट से जीरो, पर कम हो जाते हैं। So do we need to monitor adequacy, e.g. testosterone levels? No, clinical monitoring is good enough. We hardly ever measure serum testosterone levels. Clinical monitoring of pubertal progression is very good. कब तक continue कर सकते हैं? That is a tough one for me to answer. Honestly, I have never seen these people, they don't come to me at this age. But if I just go by normal physiology, I would say at an age when a woman normally undergoes menopause and a man normally goes andropause, maybe in their 50s might be a good time to stop. But honestly, I'm not the right person to answer this question, and I will not venture into an area where I have little experience. अगली बार मैं करके आऊंगी, या पेशेंट्स टेक मी बाय सरप्राइज।
हमारे लिए भी नया एरिया है, तो वी आर ऑल लर्निंग।
बट आई थिंक HCG अभी तक रह गया, मैं उसका जवाब देती हूँ।
हाँ, श्योर।
सो HCG के दो रोल्स हैं आजकल, स्पेशली बॉयज में हम प्यूबर्टी इंड्यूस करने में HCG यूज करने लगे हैं इंस्टेड ऑफ टेस्टोस्टेरोन। उसका एडवांटेज क्या है? उसका एडवांटेज ये है कि आगे फर्टिलिटी प्रिजर्वेशन में वो हमारी ज्यादा मदद करता है। सो अक्सर अगर हमारे पास पेशेंट्स आते हैं 16 इन दैट एज ग्रुप जहाँ प्यूबर्टी नहीं हुई है इंड्यूस, एंड इट लुक्स लाइक प्यूबर्टल फेलियर, अगर हम टेस्टोस्टेरोन देंगे तो उनके पिनाइल ग्रोथ हो जाएगी, प्यूबिक और फेशियल हेयर आ जाएंगे, लेकिन टेस्टिस का साइज नहीं बढ़ेगा। पर अगर अब हम उन्हें HCG देंगे, HCG से हम एक कोशिश कर सकते हैं उनके टेस्टिस का साइज बढ़ जाए ताकि वो कल को स्पर्म्स बना सके। सो इट इज अ यूजफुल मोडेलिटी। इसको अक्सर HCG को हम और भी कई सिचुएशन में यूज करते हैं बॉयज में जहां पर क्यूबिटल फेलियर है, नॉट ओनली थैलेसीमिया। आई मस्ट से थैलेसीमिया में रिस्पॉन्स उतना अच्छा नहीं है जितना दूसरी सिचुएशंस में है। इट इज स्टिल वर्थ ए ट्राई। सो हम लोग अपने सेंटर में अब इन बच्चों को देते हैं HCG ट्रायल फॉर ए गुड ईयर, इफ दे कम टू अस इन टाइम, एंड अब मॉनिटर करते हैं उनके टेस्टिस बढ़ रही है या नहीं बढ़ रही है। इफ दे डू नॉट शो ए रिस्पॉन्स देन वी स्विच टू टेस्टोस्टेरोन। सेकेंड रोल HCG का आता है जब उन्हें फर्टिलिटी चाहिए, so at that time again it can be used.
Thank you. डॉक्टर अंजू, बस आपसे मैं लास्ट में, क्योंकि समय हमारे पास कम बचा है, तो संक्षिप्त में पूछना चाहूंगी कि एक नया जो ऑस्टियोपोरोसिस हमारे लिए एक बहुत बड़ा मुद्दा हो गया है और बोन पेन उसके साथ ये भी बहुत प्रॉब्लम इश्यूज है, तो इसके लिए हम मैनेजमेंट के लिए, मुझे मालूम है ट्रीटमेंट इज मल्टीफैक्टोरियल, बहुत पेशेंट्स ये समझते हैं, लेकिन अगर ऑस्टियोपोरोसिस है तो हम उसे, हमारे लिए आज की डेट में क्या मैनेजमेंट टूल्स अवेलेबल?
ये आपने बड़ा अच्छा सवाल पूछा। ऑस्टियोपोरोसिस, सबसे पहले तो ये देखें ऑस्टियोपोरोसिस की डेफिनेशन खाली डेक्सा डिफाइन नहीं करता है, क्योंकि आजकल बहुत से पेशेंट डेक्सा कराते हैं, जब स्कोर देखते हैं -2 परेशान हो जाते हैं। सो फर्स्ट वी शुड अंडरस्टैंड डेक्सा की बड़ी लिमिटेशंस हैं, स्पेशली इन थैलेसीमिक पेशेंट्स। इंटरप्रिटेशन में एरर्स हो सकते हैं बहुत सारी वजहों से, उनके डिटेल्स में नहीं दूंगी, बट आई विल जस्ट से डेक्सा इंटरप्रिटेशन इन थैलेसीमिया इज डिफिकल्ट। सेकेंडली, खाली हम लो बोन मिनरल डेंसिटी को ऑस्टियोपोरोसिस नहीं कहते हैं, अनलेस लो बोन मिनरल डेंसिटी इज एसोसिएटेड विद फ्रैक्चर्स, फ्रेजिलिटी फ्रैक्चर्स, उसको हम ऑस्टियोपोरोसिस नहीं मानते हैं। मेरा मतलब ये नहीं है कि हम फ्रैक्चर होने का इंतजार कर रहे हैं इससे पहले कि हम उसको रोकें। सो जस्ट सेइंग दैट वी शुड नॉट पैनिक। हम अननेसेसरी सबका ना डेक्सा कराएं और ना ही, अगर फ्रैक्चर्स नहीं है वी आर गुड। हैविंग सेड दैट, प्रिवेंशन इज वेरी इंपॉर्टेंट बोन हेल्थ की, और मल्टीफैक्टोरियल अप्रोच है। सबसे पहले जो हमने पहले इशू लिया, ऑप्टिमल कैल्शियम एंड विटामिन डी स्टेटस, नॉट ओनली दैट, ओवरऑल गुड न्यूट्रिशन, गुड प्रोटीन इनटेक, a healthy balanced diet, 1. Number 2, physical activity. ये across board देखा गया है, एक good physical activity helps in building bone strength and building bone mineral density, not only in thalassemia, across all children, healthy children also. So a good physical activity is important. Third and foremost is the annual endocrine screening, क्योंकि बहुत सी endocrine problems इसको वर्सन करती हैं। For example, अगर पेशेंट में ग्रोथ हार्मोन की कमी है, पेशेंट में थायराइड की कमी है, पेशेंट में पैराथायराइड हार्मोन की कमी है, इवन एड्रीनल हार्मोन की कमी है, ये सब कमियां एक तरह से इम्पैक्ट करती है बोन हेल्थ को। सो एनुअल स्क्रीनिंग करें, इसको जल्दी पिक करें कौन कौन सी एंडोक्राइन प्रॉब्लम है और उसका इलाज शुरू करें। नॉट टू मेंशन प्यूबर्टी इंडक्शन, सेक्स हार्मोन्स का बड़ा इंपॉर्टेंट रोल है इन बोन हेल्थ। सो टाइमली इनिशिएशन ऑफ प्यूबर्टी, ऑल दिस फैक्टर्स आर द मॉडिफाइबल फैक्टर्स जिससे हम बोन हेल्थ को मेंटेन कर सकते हैं। रोल ऑफ जोलिड्रोनिक एसिड, यस, जोलिड्रोनिक एसिड ग्रुप ऑफ ड्रग बिस्फॉस्फोनेट्स हैं जिनमें एस्टैब्लिश्ड ऑस्टियोपोरोसिस है, फ्रेजिलिटी फैक्टर्स हैं विद लो बोन मिनरल डेंसिटी। Those are the patients who are candidates. आज की डेट में bisphosphonates can be used, but having said that, उनका optimal dose, frequency इतना well established है नहीं. So there are studies which have shown yes, bone mineral density तो बढ़ जाती है, पर fractures कितने कम हुए हैं, it is not very clear. Having said that, individual cases को review करके there is definitely a role for zoledronic acid now, and but not a rampant juice. उसको बहुत केयरफुली इवेल्युएट करना पड़ता है, इसके साइड इफेक्ट्स भी होते हैं। जोलिड्रोनिक एसिड को बहुत केयरफुली इन्फ्यूज करना पड़ता है। इट्स नॉट दैट एनीबडी कैन एडमिट ए पेशेंट एंड गिव जोलिड्रोनिक एसिड। आई वुड स्ट्रांगली एडवाइज ऐसा मत करें। डिनोसिमाब, आई एम इम्प्रेस्ड, हमारे बहुत ही पढ़े लिखे हैं पेशेंट्स, बट आई मस्ट से देखिए किसी भी दवाई को रिसर्च से क्लिनिकल मोड में आने में टाइम लगता है। डिनोसिमाब आज की डेट में एक प्रॉमिसिंग ड्रग है, उम्मीद है इट विल बी अ वेरी इंपॉर्टेंट ड्रग इन फ्यूचर, बट अभी भी रिसर्च मोड में है और उसके बियॉन्ड इसके बारे में अभी बात करना शायद सही नहीं।
थैंक यू डॉक्टर अंजू। अब समय के कमी की वजह से मैं अब एक लास्ट क्वेश्चन पे आऊंगी, और जो भी सवाल हम लोग आंसर नहीं कर पाए हैं वो वी विल टेक, आई विल रिस्पॉन्ड टू यू बाय मेल or through one of our panelists or from what is available in literature. ये मेरा लास्ट सवाल है डॉक्टर खन्ना और मिसेस तूली को. सो आई वुड लाइक टू ड्रॉ इन मिसेस तूली, जिनकी मेहनत से हम ये सब वेबिनार्स अब कर पा रहे हैं और आप सब तक पहुंच पा रहे हैं. और ये सवाल मुझे आया है एक 62-year-old थैलेसीमिया पेशेंट से. एक सवाल भी था और एक टिप्पणी भी थी कि हम भी यूके, जैसे डॉक्टर पोर्टर ने बोला कि वहाँ के पेशेंट्स की एवरेज एज अब 50s के है, तो हमारे पेशेंट्स भी अब बड़े हो रहे हैं. जैसा इन्होंने खुद ही लिखा, ये 62-year-old हैं. तो अब हम कैसे, उन्होंने कहा स्पेशली कि ज्यादातर मैं देखता हूँ डॉक्टर्स पीडियाट्रिशियन हैं, तो ये हमारी देखभाल कौन करेगा और कैसे हम लोग इसके बारे में आगे बढ़ें कि हम इंश्योर कर सकें कि जो हमारी एजिंग थैलेसीमिक्स हैं उनकी, कि जिस तरह से हमने मतलब अपने बच्चों की तरह इनके पालन पोषण किया है, कैसे इनको एडल्टहुड में, ओल्ड एज में भी वो केयर मिल पाए जो ये डिजर्व करते हैं. मिसेस तूली एंड डॉक्टर खन्ना.
पहले मिसेस तुली बोले. I'll request Mrs. Tuli to come first.
Yeah. Can you hear me? Yeah.
Yes.
As far as adult patients are concerned, मैं तो सबसे पहले ये कहूँगी कि हमारी कंट्री में सबसे पहले adult thalassemia care centers की बहुत जरूरत है. Because till now we have in most of the hospitals and all that, we see that the pediatric departments are there. So there is a real need to create such to treat elderly patients, adult wards in the thalassemia centers. Apart from that, I will just club it with that. I took a message from Dr. Porter. Now, I think during COVID-19, there is an urgent need to do the virtual clinics. So this is something, my request, and there are so many thalassemia NGOs who have joined us today as participants. So my request to all of them, to all the expert doctors who are here, that it's time now to think about that, because we don't want that their management should suffer. And lastly, another comment, taking a clue from the blood, blood scarcity. I'm not talking about the COVID times. I'm talking about the otherwise, non-COVID times, that we have some experts today from Punjab. We have from Bangalore, from Maharashtra, from Haryana, from Delhi. I think we should start thinking that our children, need blood, safe blood. When we talk of safe blood, in a city, we see that there is some provisions in the private hospital, whereas in the government hospitals, our children are not getting NAT screen blood, or they're not getting pre-storage filtered blood. So I think we have to collectively think of those on this area also, that in some states at least, because health is a state subject in our country, that all our thalassemics should get adequate, safe, NAT screened and pre-storage filtered blood on time. So these are the few comments that I just wanted to make.
Thank you, Mrs. Tuli. मैं फुल्ली एग्री करता हूँ मिसेस तुली के साथ, और मैंने बहुत जगह ये बोला भी है कि हम अब वो टाइम आ गया है कि हम लोगों को एडल्ट थैलेसीमिया यूनिट्स बनाने चाहिए अलग. बच्चों के साथ, बच्चों के यूनिट में ये आके बच्चे अभी तक लगवाते आए हैं, ठीक है, बट ये अब ग्रो कर रहे हैं. और जो जैसे कि एडल्ट हेल्थ प्रॉब्लम्स हैं, जो एडल्ट हेल्थ केयर गिवर्स होते हैं, दे कैन हैंडल दोज प्रॉब्लम्स more confidently. They are trained for that purpose. पर प्रॉब्लम ये है कि बिकॉज ऑफ जो पुराना इसका प्रोग्नोसिस था हमारी थैलेसीमिया का, उसको लेते हुए इसको बच्चों की ही बीमारी मानी गई है. अभी तक हर एक के दिमाग में ये है कि बीमारी बच्चों की है. तो ना तो एडल्ट फिजिशियन, जिनको कि हम इंटर्निस्ट बोलते हैं या एमटी इंटरनल मेडिसिन वाले जो होते हैं, उनको ज्यादा पढ़ाया गया, ना उन्होंने इसमें इंटरेस्ट लिया. अगर आप उनको बुलाते भी हैं तो बहुत कम इंटरेस्ट लेते हैं. सो प्रॉब्लम दोनों तरफ से, कि एडल्ट फिजिशियन लेना नहीं चाहते, इसमें आना नहीं चाहते, और ना ही हमारे थैलेसेमिक्स उधर जाना चाहते हैं एडल्ट में. एक इंटरेस्टिंग आधे मिनट में मैं बताऊंगा कि मैंने ये कोविड टाइम से पहले एक सर्वे किया था कि अपने हॉस्पिटल में हम एडल्ट थैलेसीमिया यूनिट बना रहे हैं, तो कौन कौन जाएगा. एडल्ट्स को मैंने परफॉर्मा दिया, उसमें से 2/3 ने तो कह दिया कि वी डोंट वांट टू शिफ्ट. ये एक्चुअल सर्वे है मेरे यूनिट का. और जो 1/3 जिन्होंने कहा कि हम शिफ्ट हो जाएंगे, उसमें से हाफ ने बोला कि हम शिफ्ट होंगे सेम डॉक्टर और नर्सेस के साथ. तो शिफ्टिंग काय की होगी जब डॉक्टर भी वही जाएंगे और नर्सेस भी वही जाएंगे. सो मैं आई to compromise on all this, I feel that we should jointly look after these patients when they grow to adulthood. Adult internal medicine वालों के साथ में pediatrician या जो pediatric hematologist जो देख रहे हैं अभी, they should both combine coordinated way में दोनों को देखें जब तक the concept of adult thalassemia unit अभी नहीं आता. Thank you.
Thank you. So I'd like to thank all the panelists for giving us their, insightful comments and the time today. To all of you who've joined in, I can promise you that we will answer all those questions that have not been answered on your mails. We've tried to pick a common thread, which many patients ask. So if there were specific questions with regards to your own personal situation, we will answer them. You will, within next 24 to 48 hours, we will share the link of both the first webinar. And I would very much encourage you to look at that because they were very, very wonderful talks by three very eminent people from India. And we'll share the link to this webinar as well. Please share them as widely as possible because we'd like to reach as many thalassemics as possible. So at the end, I'd like to hand over to Mr. Deepak Chopra to give the formal vote of thanks to each and every one of you. Thank you, and we look forward to seeing you at a webinar shortly again.
Good evening to each one of you. I hope you can hear me.
Yes, sir. Yes.
Well, Dr. Amita Mahajan just said that she hands over the mic or the stage in this virtual setup to me to give the formal vote of thanks, which means that the vote of thanks has already been done. I have to only do the formality. But nevertheless, sometimes formalities also carry some abnormalities. So I'm in favor of those abnormalities rather than the formalities. I would say that, this was a thought which came in our organization, the Thalassemics India, that keeping in line with our tradition that on the International Thalassemia Day, we have always been holding either some seminars or workshops. But because of these stressful times of the COVID, holding anything physically was not possible. And that brainstorming gave us this idea of holding these webinars. And today's webinar is the second one in the series. Today's webinar, as you know, has been captioned as challenges in the day-to-day management of thalassemia. I very patiently listened to each one of the speakers, starting from our own society's Vice President, Dr. Khanna, who then invited Dr. Lalit Mendiratta, then the chairperson, Dr. Sunil Bhat, an eminent and expert hematologist from Mumbai, Dr. B Agarwal, who I think as of now, he has left the chair. He's quite a busy man. Then Dr. John Porter from UK, our own executive member of the society, Dr. Amita Mahajan, who had with her the support of Dr. Deepak Bansal, Professor Anju Seth, and Professor Shruti Kakkar. I wish more stress had been placed by each one of the speakers and the panelists on today's challenges. Because today is a very special period that we are all passing through. It's been now over 14, 15 months that we are in these disturbing times, and thalassemics are facing a dual challenge. They are not only facing their monthly or bi-monthly challenge of a transfusion and management of thalassemia, but they are also facing the dreadful challenge of COVID and how to ensure that they continue to be COVID negative, how they are able to get themselves vaccinated in a country where there is a shortage of vaccines. So I was expecting that there would have been more stress on today's challenges and today's issues. Nevertheless, the talks by each one of the experts have been very, very educative. I am told by the back-end team that as we speak, about 300 people have been logged on to our webinar, though about 450 of them had originally registered. And I'm quite sure that despite the fact that these 300 of the persons who have logged on to the webinar, many of them may have issues of understanding English language, but I'm quite sure that Amitaji gave the Hindi translation or did the presentation sometimes in English. So the substance would have definitely reached each one of the participants of today's webinar. I have a last request to make that in our next of the series, Dr. Khanna and Dr. Amita Mahajan, who normally prepare the entire curriculum of the webinar, extra care be taken that we address issues of today's challenges. I know that those who are listening today, they are from different states in our own country, and the present difficult days which have given challenges of blood. My able colleague, Mrs. Tuli, who just spoke a few lines before me, talked about safe blood. I am quite sure that a lot of you may have known or heard that through Thalassemics India, we have taken up a program of safe blood to ensure that NAT tested blood is made available to each and every recipient, be it a thalassemic or a non-thalassemic. So I would like that the next webinar should have a section where the current situation challenges are talked about, where children or adult thalassemics are facing issues of transfusion because most of the facilities have been converted into COVID hospitals, the fears and the dangers which these children and adults who go monthly or bi-monthly for their transfusions, they have to face. So these are some of the issues which need to be addressed. So I personally feel that rather than devoting more time to the genesis of thalassemia, which by and large is now known to practically all the parents and the patients, the concerns are the challenges which we are facing in today's situation. Nevertheless, I have the formal duty to thank not only the speakers, the panelists, the experts. A special thanks to Dr. John Porter, because he spoiled his Sunday morning. We are all towards the Sunday evening time, whereas John had to join in as early as about 11:30 in the morning. My thanks to our sponsors for today's webinar, Fresenius KB and Sun Pharma, our supporters, the Indian Academy of Pediatrics, and we are very lucky that one of our executive members of the Thalassemics India, Nanni Singh, is running a event company known as the Showcase Events. My special thanks to Nanni Singh and her company to organize this seminar and manage the back end. So as my medical expert colleague in the society, Dr. Amita Mahajan, had said that I have to do the formality of doing the vote of thanks. With these few words, I complete my formality and look forward for yet another series of either a webinar or a workshop through this combo of Thalassemics India and TPAG. Thank you, everybody. The only thing missing in this webinar is that I cannot offer you either a cup of tea or a glass of beer. So each one of you, please decide your drink after you leave and exit out of this webinar. Thank you.
Thank you very much, everyone, and have a good evening.
Thank you, everyone, for joining us.